Yes.
Can we start?
Jignesh, can we start?
Yeah, recording has started, so let's start.
Charmila, please.
Yeah. Thank you so much. I would like to invite all of you to this unique certificate course on sexual health. And it's going to be held on 29th, 30th, and 31st of May. We are honored to welcome the chairperson of ICOG, Dr. Lakshmi Srikande, the vice chair, Dr. Parag Biniwale, all the other FOGSI members who have joined, the convener, Dr. Neeraj Jadhav, all the co-conveners, Dr. Manoj Chalani, Dr. Apurba, Dr. Madan Kamble, and the coordinators for all the days, Dr. Queen Aditya, Dr. Dibanti, and Dr. Ruma Shukla. We'd like to welcome all of you to this program, and we're extremely honored that so many of you have joined for this unique course. It will be held for 3 days, and you have to attend for all the 3 days. You have to go for the pre-assessment and the post-assessment so that you are able to attend for all the 3 days, and then you get if you get a pass percentage of more than 50%, you will be provided with a certificate. But please remember, you have to attend for all 3 days, otherwise it's not possible to give the certificate. We'd like to inaugurate the program first. May I have the prayer song by Dr. Queen Aditya, one of our singers from FOGSI.
Thank you so much, dear ma'am. Welcome everyone. इतनी शक्ति हमें देना दाता, मन का विश्वास कमजोर होना, हम चले नेक रास्ते पे हमसे भूल कर भी कोई भूल होना, इतनी शक्ति हमें देना दाता, मन का विश्वास कमजोर होना. Thank you.
Thank you so much. Such an auspicious start and with such a sweet voice. Thank you so much, Dr. Queen, for the last minute acceptance of giving us a prayer song. Now it's my honor to introduce the chairperson of ICOG, Dr. Lakshmi Srikande. She doesn't need any introduction. She has given us so much of academic fees throughout the year now, and many more to be awaited. She's a medical director of Srikande Fertility Center, Nagpur, chairperson of ICOG at present up to 23. She's a national corresponding editor of a journal of FOGSI Jogi, national corresponding secretary for AMWI, senior vice president of FOGSI in 2012. She has received several awards, has been the president of the Nagpur Society in 2006, has delivered several orations and almost 450 guest lectures she has given. So having almost 20 national and 11 international publications. May I request Dr. Lakshmi Srikande to bless the gathering before we start.
Thank you. Thank you so much, Charmila, for your kind introduction. Very good evening to one and all. And we are so happy that this time we have chosen a hatke topic, that is out of the box topic, and that is sexual health. And why sexual health is under the banner of ICOG? Because India has given Kam Sutra, we all know, to the world, and our temples, they are promoting sexuality in Khajuraho, Konark, at so many places, yet talking about sexual health is a forbidden terrain in India. And various organizations, including FOGSI, ICOG, we all are trying our level best to include sexual health in the curriculum, but still so far we have not succeeded. And that is why most of the times whenever any patient comes to us, we feel ill-equipped because we are not trained adequately as far as the sexual health is concerned. And we, especially my generation and older generation, we still have our own stigma and taboo as far as talking about sexual health is concerned. And that is why this time we have brought 3-day FOGSI ICOG online course on sexual health to educate, to make aware, and to sensitize our all FOGSI ICOG members about the importance of sexual health. And I must give full credit to the convener, Dr. Neeraj Jadhav, for coming out with such a wonderful module and with the excellent speakers who will be deliberating on sexual health, its importance, the counseling, the diagnosis, the management of sexual health in male and females will be covered in 3 days. So stay logged in and we all are here for happy learning. So at the outset, now I would definitely like to thank our FOGSI President, Dr. Rishikesh Pai, Secretary General, Dr. Madhuri Patel, and all the FOGSI office bearers for their constant support, encouragement, and guidance. And special appreciation to our Vice Chairperson, Dr. Parag Biniwale, and ICOG Secretary, Dr. Ashok Kumar. Of course, Neeraj, I have already given full credit to him for this 3-day course. I also welcome our co-conveners, Dr. Manoj Chelani, Apurva Kumar Datta, Madan Kamble, and I'm so happy to welcome our past chairperson of ICOG, Dr. Mandakini Meg. Actually, credit goes to her for starting these online certificate courses, and I'm so happy to continue her legacy, what she started, and madam, it is going great guns. For MTP course, we had more than 2000 registrations. For this, Neeraj has broken all the records. So very happy and very happy to continue what you started, that is online teaching during your tenure as ICOG chairpersons. So I also welcome today's coordinators, Queen Aditya, Dilpreet Sandhu, and all the speakers who will be sharing their knowledge. That is Dr. Sanjay Deshpande, he is from our own city, Nagpur, Dr. Narendra Malhotra, Dr. Vasant, Dr. Atmik Jain, Dr. Vijay, Dr. Mohammed, and Dr. Sunita Kandulwatkar. So friends, very happy to receive the overwhelming response for the certificate course on sexual health. And whenever we talk about sexual health, everyone thinks about the reproductive health, but this time we are keeping reproductive health separate. That is, we are having separate web series on family planning, where we are covering reproductive health, and this 3-day course is only focused on sexual health. So once again, I welcome all the conveners, co-conveners, chairpersons, speakers. Special welcome to Dr. Mandakini Meg, and welcome to all dear delegates. Happy learning. I hand over back to Neeraj for further proceedings.
Thank you so much, ma'am. Would like to have the CV of Dr. Neeraj, please.
No, madam, it's okay. Just chairperson is enough.
He's a He's a chairperson of the Sexual Medicine Committee. Actually, he wants to be renamed as Sexual Health Committee, and he has done such great work from January onwards. When the first certificate course started, he was ready with this program, and he was sending constant mails to madam asking her to confirm as quick as possible. And his planning is exemplary, execution is excellent. Thank you, Dr. Neeraj, for bringing out such a great program. I think it will be an eye-opener to many FOGSians, because we are not used to talking about sexual health, more of reproductive health we've been talking, as madam had said. I would like to welcome Dr. Neeraj to take over the program and introduce his coordinators and the faculty for the day. Thank you so much.
Thank you, Charmila. So, good evening and welcome everyone to today's ICOG certificate course of sexual health. I just remember when Lakshmi madam asked me whether you will do the certificate course in the sexual health. I was more than happy. Why? Because my sexual medicine committee in last 3.5 years have worked with so much passion and dedication. We have covered almost 200 society of the FOGSI and 4 to 5 state association. We have done program on the sexual health. So whenever we do program with the society or a state association, we always get one question: isn't there any certificate course in the sexual health from the FOGSI? So when madam asked that, I was so much happy that finally our dream will be alive to have some course sort of the certificate course. And we believe that a gynecologist have so much role in having providing our women and men also total complete sexual health, because sexual health is a part of overall health, and we can't ignore sexual health if we want to improve our health of our men and women. So we have a lots of work behind the scene to choose the subject, to choose the faculty. Me and my team has a so much many talks about whom should we be asked to give talk and which subject, which topic we have to cover. After so many discussion, we finally come with the topics and the we have. I'm glad that we have so many national as well as many international speaker agreed to do this ICOG certificate course and spare their time, valuable time, because they are top-notch sexologists across the country as well as from the outside of India. So thank you everyone, all the speaker who agreed to be part of this. And with this note, I welcome once again everyone and have a happy learning. And I wish that we take up this subject with so much vigor so that we can improve the sexual health of our women and as well as men. So happy learning, and I now hand over to our today's moderator, Dr. Queen Aditya and Dr. Dilpreet Sandhu for further proceeding. Let me share my screen for
Dear delegates, pre-test link we will be sharing just in a moment. Just wait. You just
can you
introduce today's moderators. We will take pre-test link before we start with the scientific session.
Madam.
Yeah.
Yeah.
You just introduce Queen and Dr. Sandhu. Yeah.
Yeah. So today's our moderator are Dr. Queen Aditya, who is the Eastern Coordinator for our Sexual Medicine Committee, FOGSI, and Dr. Dilpreet Sandhu, who is the State in charge of the our Sexual Medicine Committee from the FOGSI, and she is also a professor in the GCM College of the Chandigarh. So I hand over further proceeding to both of them, Dr. Queen and Dr. Dilpreet. Over to you, Queen.
Yes, thank you so much. Welcome everyone to this wonderful program organized by ICOG. Thank you, Lakshmi ma'am, and thank you, Neeraj sir, for this giving all of us this wonderful opportunity to learn. So without wasting time, first of all, I would like to invite and introduce Dr. Mandakini Meg ma'am. Can someone please come up with her CV?
Queen, we have to pre-test.
Okay, yes.
So,
But
delegates,
the test will be put up, right?
yeah. Dear delegates, we are putting the pre-test link in the chat box. Jignesh, please post the link and start the timer. You all are given 10 minutes to go through the pre-test. So once he posts, he has posted.
There are 30 questions in the test and you have to complete the test in the 10 minutes.
Test link is posted. The time given is 10 minutes. Meantime, we all will keep ourselves muted so that there is no disturbance.
Okay.
Only 1 minute left.
Seconds.
Only 30 seconds. Yes.
Last 10 seconds. So time is over.
Yes, great. So friends, now you will not be able to submit it. So don't bother about the pre-test. Focus on the scientific content now.
There will be post-test. Yeah.
And be prepared for the post-test. Pay attention to all the lectures. Yes, please start introduction of Meg Madam.
Yes. Thank you. Yes, thank you so much, Neeraj sir and Lakshmi ma'am. So now, without wasting time, I'd like to invite our respected Dr. Mandakini Meg ma'am. We all know her so well. She does not need any introduction, but still, as a formality, a few words. She was the chairperson of ICOG from 2020 to 2021. And ma'am, Lakshmi ma'am has already mentioned that all these online programs have begun only under the leadership of Mandakini ma'am. So we are indebted to you, ma'am. And we all know that she was the vice president of FOGSI between 2012 and 2013. She is holding many posts in international fora as well. She has many feathers in her cap and many accolades. She has delivered so many orations. She is the recipient of so many awards. So without wasting any more time, I would like to introduce her to our this platform. And ma'am, please give us your blessings. Thank you so much, ma'am.
So good evening, everyone. Extremely happy to see the fruits of the seeds which we have sown with Parag. Parag, thank you very much for being with me as a very efficient secretary. Of course, my Lakshmi Shikhande, that time she was chairman elect, what you used to say?
Designate.
That was a new terminology. So we all were there when I planned this, and I'm extremely happy to see the fruits of the plant, and which already everybody mentioned. That was a very difficult time, very difficult time. And with a lot of ambition, we have started as a very magnificent ceremony at Lucknow installation. And immediately, within 1 month, nobody knew that COVID is going to stop in such a way that we will not be going out and we will not be communicating with each other. So all our ICOG plans were failed. Zoom platform was not known to us, and we experimented a lot. And finally, I can say that we turned all the challenges into the opportunity, and it is one of them. So Lakshmi, I'm extremely happy that you could carry forward the legacy of those online teaching platform and the certificate courses. One line about the certificate courses, I think Parag knows, even Lakshmi knows, that there was a lot of criticism in the beginning, Parag, that we did 5-day courses, then we did 3-day courses, and then pre-test, the post-test, and finally this module was, after trial and error of 2-3 courses, finally this adolescent course by Sampath Kumari, domestic violence, family welfare, so many courses, and a little bit of the advice by the seniors, and then we came to the perfect course, which is a 50% attendance, which is a 3-day compulsory attendance with the 50% pre-test, post-test, and all 3 days, then after passing 50%. This was a formula, and which is now, working so well. And now there is no criticism, there is nothing. On the contrary, everybody is appreciating. And most importantly, in my period, I could do only 9 courses, ranging from family welfare, ultrasound to the domestic violence. And now you are taking it further. So this sexual medicine course is one of those best courses which actually we all need. And all you're adding to the courses which are already there. So I think no better way than to appreciate my work in such a way. So Neeraj, congratulations for coming out with such a wonderful model. I can see Dr. Shelani, Dr. Quinny, Parag already mentioned, Lakshmi, I have mentioned, all the people, coordinators who had done this wonderful job, and everybody coming together. Lakshmi, I take this opportunity.
Thank you, madam.
Whenever we have this, all the courses, that time we all come together. We become one unit, and then this unit takes out the subject to the highest level. So with these words, I really congratulate you and keep the good work going. Keep on involving me also whenever possible. And I think it will be very pleasure to, coming back to our own home, that is ICOG. So thank you very much for inviting me to this forum.
Very good evening, ma'am. Thank you so much for the encouraging words to our
Thank you,
committee.
madam.
Ma'am, now I seek your permission to call upon our first speaker.
Yes.
And
Yes.
who is none other than Dr. Lakshmi Srikhande. Madam has been already introduced to today's gathering, but still a brief introduction. Madam is chairperson ICOG and national
It's okay,
correspondent.
let's repeat, it's okay.
It's okay,
We
please.
welcome you, ma'am.
Yeah. So
Just a minute, ma'am. I'll be going to interrupt you 2 minutes prior to the this
I
time
will,
given.
please don't interrupt me.
Thank you, ma'am.
So friends, I am the opening batsman and I am giving you the overview of sexual health. We all talk about physical, mental, spiritual health. During COVID, everybody became spiritual, cultural, social health, financial health, environmental health, but we never talk about sexual health. And remember, all these types of health, they can impact each other. Sexual health is as important as all these types of health, but how important it is, it depends on each person, and it is different for each person. Why? Because depending on where you are in the world, your upbringing, sexual health is different for each and every individual. When we talk about sexual health, remember, it's a large term. It is common. When we utter the word sexual health, it is quite obvious that everybody thinks that we are going to talk about sex. But did you know that sexual health is so much more than the act of sex? So it is a very, very broad terminology. These are the various components of sexual health, which we will be covering. And when we talk about sex, why we are having so much taboo to even utter that word? Can you see? There are so many benefits of having a good sexual life. And there are many advantages if we start talking about sexual health. Right from prevention of sexually transmitted infection, it will encourage the safe sex practices. Of course, reproductive health is one of the component of sexual health. It will promote healthy relationships and positive body image, and it will boost the immune response and your health. So what exactly influences sexual health? It is your own values, beliefs, upbringing, culture, your religion, your spirituality, people around you. They also influence how you think about the sexual health, our personal experiences, social expectations, and legal and or sexual rights. So do we have a definition of sexual health? Yes, we do have, although it's a very, very difficult task, because again, I will say, because of the different culture, subculture, and the different upbringing of each and every individual. Here, I have shown you the definition by American Sexual Health Association, that it is the ability to embrace and enjoy our sexuality throughout our lives. It is an important part of our physical and emotional health. Being sexually healthy means you understand your sexuality, you recognize and respect the sexual rights, having access to sexual health, you make an effort to prevent unintended pregnancy, being able to experience sexual pleasure, and being able to communicate about sexual health. WHO has also given definition of sexual health that it is a state of physical, emotional, mental, and social well-being related to sexuality, and it is not merely the absence of disease, dysfunction, or infirmity. When I was preparing for this lecture, before that I was really not knowing that there is a World Association for Sexual Health, and this is an international umbrella organization which represents sexological societies and sexologists worldwide, and there are 5 prominent regional continental federations who are member of this association. And in 2010, the World Association for Sexual Health, they instituted September 4 as the World Sexual Health Day in an effort to increase the awareness about the sexual health. And the Declaration of Sexual Right was first proclaimed on the 3rd World Congress of Sexology in Valencia, 1997. And the current version, which we all are following, is from 2014. Friends, sexual problems are very, very common. The perception of sexual problem is subjective. And remember, not everyone who is experiencing a sexual problem is necessarily distressed or sexually dissatisfied. These are the categories of sexual responses in the male, in the female, which we are going to deliberate in detail in these 3 days. I am so happy that Dr. Atmik will be covering the male sexual response and female sexual response in his talk. And this is the new view of women's sexual problems, because as a gynecologist, we do hesitate, we don't inquire, they don't open up with us, and there is a problem of sexual health in majority of the females. And these are the various classification categories, that it can be because of sociocultural, political, or economic reasons, can be because of partner relationships, it can be due to psychological factors, and it can be due to medical reasons. So these are various common psychological problems which are associated with the sexual problem. These are various relationship issues which can also affect the sexual health of that particular individual. And when we say female sexual health, friends, 40% of our women, they suffer in silence. They just don't open up. And as a healthcare provider, which I was talking, we also don't open up because of our lack of training and skills to deal with this kind of sexual health, embarrassment to talk about sex, concern about offending or embarrassing the patient, underestimating the prevalence of sexual dysfunction, and underestimating the impact of these sexual complaints on her quality of life. So let's talk about sexual issues and why we have to bother about this female sexual dysfunction. Again, because it does affect her quality of life. So what is it? That is why this course is all about. That female sexual dysfunction, it is a condition in which a woman experiences persistent and recurrent problems with any aspect of her sexual activity. These are the 4 categories: problems with libido, problems with arousal, problems with orgasm, and problems with pain. These are various factors which affects her sexual health, and this is how age itself affects her sexual health. After the menopause, because of the vaginal dryness, she faces many sexual problems, and all these sexual problems are linked to each other. Approach to these patients, the medication which impacts this female sexual dysfunction, and the treatment which we will be teaching you all in this 3-day course. So the key points from my talk is diagnosis and management of some sexual dysfunction cases are highly complex and time consuming. They do need appropriate referrals to sexual health specialists. Avoid assumption that pelvic pain is a psychological thing in a female. Because you are unable to identify the cause of the pain, that does not mean that this patient is having a psychological pain or it is a psychosomatic disorder. When the cause of pain cannot be really diagnosed and treated, consider referral to a pelvic pain specialist or a pelvic floor physical therapist. In cases of low desire, decreased arousal, or orgasm, consider all potential physiological causes, including complaints resulting as a side effects of medication. And you have to think again about appropriate referrals to sexual health specialist, endocrinologist, or to a physician. So to conclude, female sexual problems are highly prevalent. Patients want to discuss concerns about their sexual health with their healthcare provider. So if they open up, try to give your ears and your time to these women, and an integrative approach is required with attention to biological, physiological, relation, and contextual contributors to the sexual problem. So thank you so much for your patient hearing, and let's have happy learning on all 3 days about the details of sexual health. Thank you once again.
Thank you so much, ma'am, for such a crisp overview of sexual health. Thanks. Dr. Quinn, please take over.
Thank you, Dilpreet. Next, I would like to invite our chairperson, the man behind the entire show, who has taken so much of pains and put in so much of effort for making today happen. So I would like to invite our chairperson, Neeraj sir.
Thank you, Queen. My slide is visible? Hello,
Yes,
Queen?
absolutely.
My slide is visible? Yeah.
Yes, yes, visible.
So Lakshmi Madam nicely elaborate what is sexual health, why it is important, and what is the overall broad view about the sexual health and some of the sexual dysfunction she nicely described. So now patient has some doubt, see there's some sort of sexual problem. So where should she go? Or he should go? So I am focusing some of the points. How sexual health and gynecologists relate, or what is the role of gynecologist in case of sexual health. So sexual health is a key aspect of women's overall wellness. Obstetrician and gynecologists, with their professional knowledge and training in the female reproductive system and related disease, must play more role in managing female sexual health. However, it is unclear whether obstetric and gynecologists can effectively manage patient of the sexual health or with the sexual problem. Let me ask you all of you one question. Do you ask your patient about their sexual health or any time during their visit to you? So let us, I found this study which was done in the China. There were around 3,000 participants invited for this study. Out of this 3,000, only 1,300 responded to the query. We are also doing one survey about the through FOGSI and through my committee about the attitude and practice of the sexual medicine among gynecologists. We have sent messages to almost around 30,000 people, but up till now we hardly get 1,000 responses. So you can understand how we are not that much sensitive to this topic about the sexual health. In this survey, 80% reported not receiving any training in female sexual health, and only 1.24% had more than 10 hours of training on female sexual health in medical school. Pure obstetrician knew about and used SEOG guidelines. Around 3.5% used this SEOG practice bulletin clinical management guideline. Around 2.8% were using classification of the female sexual dysfunction guidelines. Around 3% were using the female sexual function index for their patient. On the knowledge test, 8% answered 6 or more questions out of the 10 questions related to female sexuality correctly. So you can understand what is the situation. When asked whether they would routinely assess patient sexual activities when taking medical history, only 6.4% OBGYN reported they collect information at every time. So this is only 6.4%. they ask about the sexual history. Only less than 1/3 of the OBGYN express confidence in their ability to manage patients with a sexual health, often or almost every time. And approximately 1/4 reported that they lack self-confidence in managing such type of patient. So this is the scenario. It is a study of China, but we are in the same boat culturally to China. So it's same situation in India also. A multiple choice question indicates that the lack of specific knowledge, unfavorable clinical environment, like there is a sharing of the consulting room, or there is a lack of primacy, and lack of effective treatment method, including drugs, were the major obstacle in screening and managing the patient of the female sexual health. This is another study in the Switzerland. There were around 341 gynecologists who responded. That again, it was only 40% respond rate. Among them, 40% reported having at least brief training in the sexual medicine. 7.9% responded routinely explore sexual issue with more than 80% of their patients. So it is only 8% gynecologists in Western country also they ask about the sexual history. 28% responded offered appointment specifically for the sexual issue, and 85% proposed such type of patient to the specialist collective. Lack of motivation for therapy on the part of patient was mentioned as the most common cause for persisting system, around 63%. Dyspareunia was quoted as the most or second most prevalent type of female sexual dysfunction by 77% of the responder. So in conclusion, we conclude that among Swiss gynecologists, sexual problems are regarded as an important issue in gynecological as outpatient care, but addressing patient sexuality is not yet part of routine practice. So this is the Western data. Sexual health, perhaps a gynecologist is the only professional a female can freely discuss the issue pertaining to her sexual life and her well-being. Hence, periodic follow-up with the gynecologist will help establish a rapport where they can discuss awkward yet vital aspects of sexual health and seek immediate remedy. In the 2023 annual meeting of the Society of General Internal Medicine, experts said that patients want to talk about this problem, but they need their physician to be ready for the conversation. So we all should have this 5A framework. First A is the ask. Start by asking patient if they would be comfortable with you posing a few questions about their sexual health. Second A is advice. Make sure your patient know that many women struggle with the problem of such type that they have raised. Third A is the assess. Ask a set of standardized assessment questions. Fourth A is the assist. Assist means tell your patient about the treatment option. And fifth A is the arrange. Arrange a follow-up visit to see if the treatment has been effective. So we all should include this 5A in our daily practice. So sexual health should be on our writing pad. So every patient has a right for better sex, good relationships, and healthier body. So patient have so many questions, but we are ready with the answer. So let's be ready about the answer about the sexual problem from the patient, and such type of courses will be helpful to you in solving their question. So thank you for your patient hearing. Over to you, Queen.
Great, Neeraj. You have really emphasized why at ICOG we are having this course, because it is badly needed for we only gynecologists, because we have so much taboo, stigma, and we are not ill-equipped and very well trained. So very well covered the importance of learning sexual health by we all gynecologists. Great, Neeraj.
Exactly, ma'am. Thank you so much, sir. Actually, you have raised the point that why we need this kind of a course. Most of us are not geared up or not equipped with the knowledge or as to how to address these issues, how to help our patients. So this kind of a course for us, the gynecologists, as you have mentioned, that most of the patients are willing to talk to us, but they are not sure whether we are willing to take up their cause. So thank you so much for bringing up this topic. And now I invite Dilpreet to continue.
Queen Meg Madam is here. Madam, you want to give your comments on these two talks?
Okay.
Because you might leave. Yeah, so your comments here.
Yeah, definitely. Lakshmi, as you have said very, very correctly, that nowadays in the practice, whether it is for the women or even for the adolescent, yesterday I was giving oration on the adolescent, same problem with the sexuality discussion in public, it has become a taboo. And bringing out the subject, and most importantly, what we need is in the OPD itself is a lot of confidentiality, non-judgmental, because whenever she wants to tell you some problem, so the attitude should be non-judgmental, and it should be a lot of confidentiality, and you should listen to the patient. Then only actually you can give them the proper advice. So with this, I think you have taken the subject further. Also, Neeraj has given the sexual function and the gynecologist. I think that is also justified in each and every way. And I just want to say further that in the OPDs also, as we have said for the adolescent health, there should be some time, special time given for this problem. Because if it is in the line or even you got crowded OPD, it is very difficult that they open up. So yesterday there was talks were going on that give some special time if they have sexual problems or something. So give, say, in the afternoon or some 1 hour or some, and call the patient that time. That will go a long way in solving the problem of the women with the sexual problems. And instead of bringing them in the main OPD and discussing, so that is my suggestion. So thank you very much, Lakshmi and Neeraj.
Thank you, Mandakini ma'am. Thank you so much for giving us your blessings. Thank you so much.
Madam, problem. Let's do one thing. Sometimes what happens, the patient directly not come with the problem of their sexual issue. They have some other complaints, but behind that complaint, the reason is their sexual dysfunction. So we have to just dig out the problem.
Even they come with the headache.
What is the real problem, and if necessary, we can ask them to come on the separate hours.
And pain, pain.
Yeah, they come with very different problems,
Yes.
and then you have to derive and come to that. So I think that is a skill of you people who are doing so much in the sexual health. So
No, we want every gynecologist is sexologist.
yeah, I understand. So
Great.
okay.
So, welcome. Thank you so much, Meg Madam. And now we welcome our very own sexologist from Orange City, Nagpur. So, Queen, please introduce Dr. Sanjay Deshpande.
Yes, thank you so much, ma'am. Dilpreet,
Dr.
please.
Sanjay.
So our next speaker is Dr. Sanjay Deshpande. Sir is past chairperson, Council of Sex Education and Parenthood International, and Sir is honorary secretary, Indian Andropause Society. I welcome you, sir, to talk on this very important topic of importance of sexual health.
So thank you very much. At the outset only, am I audible?
Yes.
Yes, sir.
Yes.
So thanks to
Yes,
Dr.
sir.
Lakshmi,
Thank you, sir,
to
for
whom
joining us.
I always,
Yeah.
I fondly call her my Tai. She is elder than me. So she is elder sister of mine. So thank you, Lakshmi Tai, for giving me an opportunity. Thank you, Neeraj. And thank you, Apurva and Dr. Mandakini Meg Madam, who are here. All these are stalwarts of OBGY society all over India. So the topic given to me is importance of sexual health. I will be very crisp because the time given to me is 10 minutes. So I wanted to show you what is the total paradigm or what is the total horizon of sexual health. That is very important for all of us. As you know, I am a person from community medicine. So we'll always like to have a definition from WHO. So sexual health is a state of physical, emotional, mental, and social well-being related to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationship, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, and violence. As you see, the scope is very vast. Sexual health has very wide dimensions. And for sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. And if you see that there are new dimensions to the sexuality also, it is not same. So CDC has given 5 P's, that is parent, partners, practice, past history of STIs, protection, pregnancy prevention, reproductive health plan, and last one, which is recently added, that P stands for pleasure, which explores sexual satisfaction, functioning, concerns, and support for one's gender identity and sexual orientation. So here we cover everything which is about sexuality. It should be noted that sexual health is a concept undergoing evolution because sexuality is changing. What behavior will be common in future, we never know. So there may be many additions to the sexual health horizon. The term generally includes a focus on health and wellness rather than the disease. Now here, I really congratulate you all that you have shifted from sexual medicine to sexual health, because medicine is a part of health. It's not overall health. Health requires many other things. I will not go into the details of community medicine, but we know that health is a broader and wider term than medicine. The term generally includes a focus on health and wellness rather than the disease, and appreciation for the intrinsic importance of sexual health as part of overall health, an attempt to address comprehensively a range of outcomes of public health importance. So this is what public sexual health is, and we are now going to see how it is important. These are many benefits of sexual activity. We always say, I will not be limited to sexual activity, but just for the knowledge of everybody, it is very good sexual exercise, very good exercise, physical exercise, which can reduce blood pressure, increase the immune response, better heart health, possibly including lower risk of heart diseases. As all of us know that erectile dysfunction, a man suffering from erectile dysfunction is double the risk of getting MI or coronary artery disease than a man who is having normal erections. Sexual activity increases the self-esteem and decreases depression and anxiety. Though I have told the benefits about men only, but let me accept it very frankly that these benefits, I got it from internet, which has told for women, those women who are having good sexual activity, they have all these benefits. So sex is not only for men, it's for women also. And that's why, as all of you are taking more interest, you will get and you will help more and more women about their sexual health. It increases desire, immediate and natural pain relief, better sleep, increase intimacy and closeness to a sexual partner, and overall stress reduction, both physiologically and emotionally. So these are all the benefits of actual sexual intercourse. But as I already said, that we have to look beyond sexual intercourse. We have to look into the overall sexuality. And then only we will be understanding what is the importance of sexual health in a broader social, psychological, emotional, marital, spiritual dimension. So this is what importance of sexual health. We have to understand that sex is a very positive thing. Everybody is a sexual person and everybody wants to enjoy sex, sexual pleasure. So most important thing in preaching sexual health is that everybody must understand that they are sexual being as a human being. So they can express their sexual pleasures, their sexual desires in different ways. Now, pleasure is very important. We understand our system or our tradition. We always believe that we should give something to others. And this is very important in sexual pleasure also, sexual health also. If you are sexually healthy, now healthy means what? You are free from various myths and misbeliefs or myths. You are free from sexually transmitted diseases and you are free from any sexual problems. So if these three things taken together, then only we can say that we can take the pleasure more effective. And that is how sexual health is important. And that's why I always say that for achieving the sexual health in the society, in the state or in the nation, at any age, for that say adolescent, before marriage, after marriage, during say mid years of the life, or in geriatric age, sexuality education is very important. One has to understand what are the knowledge about sexual right. If we give more importance to sexual health, every person will be able to understand what are his or sexual rights. This is related to all LGBTQIA and many sexual minorities together. So acceptance of sexual minorities also is okay, is also important. That also we can achieve through sexual health. Healthy adolescence is important. As I told, that sex and sexuality is not a stationary phenomenon. It's not only affecting only one age. It's a lifetime phenomenon. We always say that sexuality is from womb to tomb, because there are radiological and sonographical evidences that a fetus, male fetus, shows erections of the penis inside the womb also. So our functioning of sexual organs starts in the womb also. So we say it is a lifetime phenomenon or lifetime sexuality. During adolescence, if you want to develop a healthy adolescence, we have to educate them through adolescent education, through sexuality education, through life scoping skills. This is what is sexual health. Health is understanding what is important. Health is your knowledge, attitude, and practices. Now, if the knowledge is good, appropriate, then only attitudes will be appropriate, and then only will be practices which will be healthy in nature. And that's why education is the most important thing in sexual health. So healthy adolescent, happy marriage. There are many things that people don't understand. That after marriage, if they don't function normally, they should go to somebody, some allopathy practitioner, some gynecologists, some urologists, some psychiatrists, some sexologists, or at least to their family physicians. But they don't go because they don't know. Why they don't know? Because we don't talk. We don't preach. We tell them that they should not indulge in alcoholism, hookah chewing, or smoking, or in theft, or in any antisocial activity. But we never tell them that sexual health is also important. If you have so doubts, you should be able to discuss it with your either parents, teachers, or doctors. Even in aging also, many physicians, they come across patients from diabetes, hypertension, coronary artery diseases. Sexual health is important for them also. Their disease also is important contributor for their sexual dysfunctions. But the specialists treating them in these conditions, they don't discuss with them. So let us talk about sex with our patients should be the main take-home message for all of us. Association with comorbidities, because a lot of diabetes, hypertension, coronary artery diseases, thyroid dysfunctions, many of the gynecological conditions, even pregnancy. Pregnancy also can affect sexual problems, sexual life. Infertility also can affect sexual life. So that is also important. Apart from all these things, we say pregnancy is not a disease. But the man and women, they don't ask the gynecologist. And gynecologists also don't know how to take sexual pleasure during these 9 months of pregnancy. That is also important. Oncosexuality is a leading branch nowadays in sexuality or sexology. That there are many thousands and lakhs of patients suffering from.
Sir, 9 minutes over, 1 minute left, sir.
Okay. So sexuality of physically and mentally challenged people, that is also important. Most important thing in sexuality education is gender equality, which can reduce intimate partner violence, domestic violence. There are many studies in literature which quote that if the sexual functioning of a man or a woman is good in their house or in their family, they are more efficient at workplace. And last but not least, sexuality and good sexual health is the most important parameter of quality of life. So these are all the things which are very important. So last sentence I will say, and I will conclude my talk, that despite the high prevalence of sex problems, discussions about sexual health are uncommon in clinical encounters, perhaps in part due to underlying assumption that sexual health is not a priority. Patient may assume that their clinicians will tell them if sexual side effects are associated with a disease or its treatment. And clinician may assume that patient will initiate discussions about sexual health if it is important to them. So last, only one take-home message, that let us talk about sexual health with our patients. Thank you very much for giving me this opportunity. Thanks a lot.
Thank you, sir. Thank you so much for the great talk and highlighting the role of sexual health. It's one of the very important parameter of individual's health. Thank you. Over to you, Dr. Queen.
Thank you.
Thank you so
Sanjay.
much.
I know how passionate you are about teaching of importance of sexual health to the general public, to the gynecologists, and to the doctors of all specialties. And we are so happy that you could spare your valuable time for our certificate course. So thank you so much for enlightening our delegates. Thank you.
Thank you, Lakshmi.
Thank you, sir. Thank you, Dilpreet. So now, without wasting any time, I would like to invite Dr. Narendra Malhotra. Sir, everyone knows him. What I don't have words to speak about him. He was the past president of FOGSI, ISPAT, and all of that. He has been founder editor of the SAFOG
Give
Journal.
me 1 extra minute. Don't read this.
Sir, all I want to say is that we all know that you're an excellent orator, and we all know about your subtle sense of humor. I can't wait to hear you punch the two together, your knowledge and your humor. I just can't wait, and I'm sure no one can wait. So please, sir, it's all yours.
I hope the sex brings out the best of it.
No, you always bring out the best. So
Welcome,
Okay.
Narendra sir. Welcome to ICOG platform once again.
Sir is
Just a
always
second.
there when we ask.
Yeah, you can see my slides.
Yes,
Yes,
yes. Very well.
So what I'm going to take you is quickly through what is sexual dysfunction and how it is classified. So we know that sexual activity is physical, however, and therefore the sexual dysfunction can be understood as problems of any phase of sexual response. And it is now being seen that a lot of people are coming with these dysfunctions for a lot of medications. So when we say what is sexual dysfunction, well, it is primary or secondary. That means it started right from puberty or it has developed later on. And more individuals who are living late into life are now coming with these problems. So we are going to learn or try to learn how to treat people older than 60 or more with this sexual dysfunction problems. So firstly, let's briefly understand. I know there's a whole topic on this. I'm just going to say a female sexual response cycle is desire, arousal, vasocongestion, orgasm, and resolution. A male sexual response is just excitement, plateau, and orgasm and resolution. So that's how the sexual cycle is. And anything which goes wrong in this is going to be classified as sexual dysfunction. So dysfunction of sexual desire, that means there is hypoactive sexual desire disorder or aversion to sex, that is sexual aversion disorder. Dysfunction of arousal is male erectile. In male, it is erectile. In female, it is sexual arousal disorder. Dysfunction of orgasm, male orgasmic disorders, female orgasmic disorders, or premature ejaculation, or delayed ejaculation, or no ejaculation. Sexual pain disorder, dyspareunia, and in women, vaginismus. So these are broadly how we are going to classify all the sexual dysfunction. Of course, there are some academic classifications we'll just go through. So when we say there are sexual problems in human beings, it is either abnormal sexual disorders, sexual dysfunctions, paraphilias, or identity disorders, gender disorders. So broadly, the whole subject is sexual and gender identity. Today, we're going to only focus on sexual dysfunction and a little bit of paraphilias. I'm just going to enumerate for you all. So the other definition which we go or classification is that there are 4 categories: sexual desire disorders, arousal disorders, orgasmic disorders, and pain disorders, according to the sexual cycle as we just showed you. So let's see how we categorize these into DSM-4 classification as 7. Now it is 10. We'll tell you the 10 also. So desire disorders, arousal disorders, orgasmic disorders, pain disorders, dysfunction caused by general medication, substance-induced sexual dysfunction, and sexual dysfunction, which is not specified in all these. So could be other causes. Then we could go to the types. Types is again as we told you about the normal sexual response, if that is abnormal, that is the type of disorder it is. Desire, arousal, orgasm, or pain. So these are the 4 things. So Diagnostic and Statistical Manual of Mental Disorders, that is DSM, classified female sexual disorders into the 5th edition DSM-5, it is DSM-10 now, into these 4, which I've just told you. Why it happens is women, because of menopausal change, because accompanying changes in the sexual function, decline of libido, responsiveness, and third is because of the testosterone libido and decrease of clitoral vulva, and then fatigability. Every time feeling tired, and that is why in men, the andropause is not as common as we see. It's not andropause, it's sexual dysfunctions. But there is a gradual decrease in testosterone, and this will bring out finally after the age of 60s or 65, and even earlier to some people now, a gradual decrease in sexual functions, desire, erections, ejaculations. And with the age, as you can see, the testosterone levels are going to fall because of the declining levels. So all this has led to late life sexual dysfunction. And this is what we're going to face with all of us in women. And so many of them are not going to come out and tell you. So you have to ask leading questions to it. And now this is occurring, unfortunately, in a very busy career-oriented couples in 40s. And that is very shocking. When they come to us, I can't have a baby. Oh, okay, what is your sexual life? Oh, once a while. Now, once a while at 40 is absolutely not acceptable. So in women, it is the interest which goes, the arousal which goes because of lower sensitivity, because of estrogen. The orgasm is not there because of either the men coming in earlier or the arousal disorder is there. And of course, pain is there because of the dry. And a lot of time there is a penetration disorder where it becomes, and this forms a vicious circle. So sexual pain, hypoactive stimulus, orgasmic disorders, all that will lead to more and more and more problems, leading to familial problems. So these in the late, as we told you, these are all going to happen. Now, what works for arousal? In men, it's just a single button. In women, there are very complex, lot of buttons which have to be fine-tuned. And if you don't press the correct buttons at the correct time or don't ignite the correct emotions at the right time. So it is said that men need place, women need love. That's for sex. And that is what should be kept in mind. You see the female brain. When a female brain for sexuality is talked about, the sexual part is a very small part. The rest is all talking, headache generators and all that. So that's frequent headaches for during, or we call it sexual headaches. While a male brain is just a single switch, as you told. So they will develop aversion, and these aversions will make them or fit them. So how does this DSM classification occur? 1952, the DSM-1 came, and then DSM-2 classification, DSM-3, DSM-4, psychiatrists, and they kept on evolving it and classifying these disorders as they tried to separate all of them and not singly label them. So the DSM-5, which a lot of people still follow, is what I've been telling you right now, all these 5. And but it is the DSM-4 was classified as this, but it is today the DSM-10, which in the male DSM-5 was male hypoactive, erectile dysfunction, sexual interest loss, premature ejaculation, and this was classified. But today we have the ICD-10 classification. So desire, arousal, orgasm, pain comes as 1 and not as separate. Lack and loss of sexual desire comes 2nd. Sexual aversions come as 3, and a loss of sexual enjoyment. Excessive sexual drive has been put into this. Failure of genital response, whatever the reason is, it's not getting on. You're unable to start the thing. And the orgasmic dysfunction, premature ejaculation, non-orgasmic dyspareunia, or non-orgasmic vaginismus, and other sexual dysfunction. And then you have a unidentified sexual dysfunction. So let's see quickly on the male part. The male sexual desire, monosymptomatic criteria, low desire for sex because has fantasies of this. Duration is about 6 months. This could start off from early as primary, but usually is secondary. And sometimes it could be because of mental illness, medical illness, and psychological. While and then that leads to a failure of genital response. So cannot get it up. That's what it is. And of course, for this, the simplest treatment was the Master Johnson techniques, and I'm not someone else is going to deal with it. So erectile dysfunctions, inability to have an erection. Inability to have an erection and sustain an erection. They have an erection, but unable to sustain till the time of penetration. That is what it is. So there is a noticeable decrease in erectile rigidity with age and with the test and with psychological disturbance. Lots of treatments. You have tablets, you have injections, you have suction devices, you have intraurethral pellets which can be injected, and we have penile implants finally for those who have real problem of the vascular dysfunction and no blood is flowing. The ejaculation disorders is premature, and the premature ejaculation again has 4 criteria. The consistently ejaculating within 1 minute of vaginal penetration or even before penetration. Criteria A has pointed so far 6 months. If it is happening, then it is classified in this, and symptoms result in clinically significant distress to this. So this can be further classified as lifelong, acquired, subjective, and variable. And that is what we need to be talking about and trying to figure out, and that's where the treatment will be aimed at. For them, of course, self-treatment for premature ejaculation is one of the more modalities. Again, I'm sure this is going to be discussed in detail, so I'm not going. Some men may have delayed ejaculation and priapism, and that or an ejaculation, and that also is a sexual dysfunction and has to be looked at if that is a problem. With the female, the arousal disorders, complete lack of or complete reduction or a significant reduction in the interest and arousal. And this will be absence of interest in sexual activity, absence of fantasizing, and even getting erotic thoughts. These symptoms persist for 6 months, then it is dealt as a problem, and this could lead to significant distress and not explained by any other condition. So the sexual arousal disorders can, of course, be now treated with some drugs. Some of them work, some of them don't work. With women, what works is, as I told you, stimulate the right areas in their brain. And the right area is the front, shows and dresses, love and emotion, frequent kissing, frequently telling them you are the most beautiful thing in the earth, and frequently telling them I love you, surprise them with gifts, give them a flower every day, and see everything will work. So all this will go away. So women can also be given self-stimulation exercises and etc. But the main thing is the communication and a couples therapy, and that is what is going to be required. The female orgasmic disorder, which comes in the DSM classification 3, the sexual action starts, but there is no orgasm. Now, females will have a delayed orgasm, and there are 2 types of the clitoral orgasm or a vaginal orgasm. So that is why the G spot is there in there. And with the correct positions, correct state, stimulating manually with the G spot and using some sex toys, etc. and all would be a. So where is my orgasm and where is my orgasm could be with both of them. So with men, it is easy. You can give them sildenafil or tadalafil. With women, it is a little more complex. Genitopelvic pain at penetration. Now, this could be because of mucous membrane, pelvic floor, sexual relationships, psychologically, and could be lots of this. See, there are so many areas here which could have been infected. The clitoral infections, urethral, labia, majora, minor, vagina, the whole perineum, the vestibule, and the anal. So the pain could be anywhere, coming from anywhere. And we need to break this pain, the dyspareunia pain. And there, again, exercises, soaking yourself in hot water with Epsom salts, and psychological is there. Of course, we can do some laser therapies, but let pain not interfere. And then we can use a lot of devices to correct this pain. So it's a couple problem. The couple have to decide how to get out of this pain cycle. So schematically, all the sexual desires can be put them, and they have one common black area in between. And that is the mental area. Sex is in between your ears, not in between your legs, and that has had to be addressed. Some of the other sexual disorders which are not classified, substance abuse, unspecified ones, some specified ones. And how do we treat them? You have They could be lifelong, acquired, generalized, situational, or degree, and depending on how they are, treat them like that. If lifelong vascular, they may need implant. If vaginismus, they may need vaginal dilators and therapies like that. The main thing is that you have to modify lifestyle. So healthy eating, no smoking, keep away from recreational drugs. As Shakespeare said, alcohol will increase your desire but take away your performance. So that is what it is. So treatments, of course, there are many I'm going to just briefly tell you sexual therapy is very important, and what we are using now is the lasers. So the vaginal, we are using the fractionated carbon dioxide laser for those who have vaginal problems. So this has shown us solve it. So it is not only used for cosmetic, it is used for functional problems also. And then we also advise them, because Kegel's exercise is very difficult. So this Femi chair could be for both men and women both. And it gives electromagnetic massages from below for improving the perineal muscles, and even for men for prostate muscles, and for improving the sexual dysfunction in men also. So it's very simple. Twice a week, so thrice a week, half an hour, just sit on the chair, read a book, watch a TV, and that's it. Briefly, what are paraphilic disorders? There are 8 of them. Fetishistic disorder, which is far more common in men than in women. So they get fantasies with the objects the women wear. That could be women's underwear, shoes, clothes. Pedophilic disorders, that means the disorders triggered by child. So the thing is with the child and prepubescent child.
So
Voyeuristic disorders, this could be in both. I mean, you feel like peeping Tom into the bedrooms, I've seen multi-storied building, people have got big binoculars and big telescopes looking into the other buildings' windows, which are open for women and men both. So this is a common disorder. Exhibitionists, some of the men will just open everything and show. Even women have been shown exhibition disorders, and these are all psychological. For stick disorders, and this is like unsuspecting person you're touching. So that good touch, the bad touch. So the good touch and the bad touch, this is the bad touch disorder. Sexual sadism and masochism disorders, like tying, beating during sexual or trying to, and masochism, recurrent urge or behavior to wanting humiliate the thing, and that somehow gives them more pleasure to both of them. So these are the disorders. And there are many more paraphilias. Chronophilia, infantophilias, pedophilia, genetophilias, telephone oral sex philia, zoophilias, that means with animals, chorophilias, clisme, and homosexuality used to come in here, but now with the getting legalized, same-sex probably marriages also, but live-ins being legalized, this has been taken off. Again, the etiology and treatment. Rape also comes here. In this is classified as sexual dysfunction of unknown. So for this, we need highly specialized physicians. And I congratulate ICOG for making this course available so that everyone who's attending, I see 400, 500 people attending, at least know what these are and know how to handle these. So the take-home messages, ladies and gentlemen, is you need to increase awareness, remove the social stigma, talk sex as he said. So there's no harm in talking sex. You eat, no, that's a biological function. Sex is a biological function. So there should be no hesitation on talking, and motivate and counsel the patient to talk about their sexual health. So ask leading questions. She might have come to you with any other problem. She's hesitant, talk to them. Then she'll send the mother-in-law out and talk to you. And then you call the husband and all, and offer them whatever treatment which you have as non-invasive as you can. So with those few words, my last punch is dhun badal kar to dekho, sab kaam karega. Thank you very much for inviting me here to express some of my views and to give me an opportunity to be a part of a subject which I'm handling almost every day, because we have a huge non-invasive treatment modality available to us. So thank you very much.
Thank you so much, sir. Thank you so much. It was so nice, as always expected from you. And the addition of the Femi chair has given all of us something to think about. Thank you so much. And so I hand over the session now to Dilpreet.
Thank you, Narendra sir. It was a very, very informative talk for all of us. Thank you.
Next, it's my proud privilege to invite Dr. Sunita Tandulwadkar. Madam is past Vice President West Zone FOGSI, President FOGS, Chairperson, Founder, Honorary Secretary ISAR, Senior Vice President ISAR, President IAG, and many more prestigious positions Madam is holding. I welcome you, ma'am, to talk on premarital sex counseling.
Madam,
Thank you. Thank you first the entire team यार ICOG लक्ष्मी श्रीखंडे कहाँ हो वहां से मैं तुम्हें साष्टांग नमस्कार. The way ICOG is rocking is unbelievable and unbeatable. And you have taken the chairpersons. Every chairperson is working beyond. Neeraj, I have received the phone call probably 4 weeks ago blocking. And then your national coordinator, Apurva, he helps you in making a presentation also. What, Apurva, thank you so much for all the things what you do and you help us. Thank you so much for being here. And Queenie, thank you for being there to chair the session. Lovely to see you, dear. Namaste and thank you, Lakshmi, once again. My words fall short. You know, the certain friends, you can't describe them in the words. You know that they are there. That's enough. Thank you, Lakshmi. Now, premarital counseling. I should say premarital sexual counseling. Probably he made Neeraj the fantastic chairperson who works always with the contras. He has a friends who are the chairperson of contraception committee and the MTP committee, rightly selected, and made me work and read a lot. So friends, marriage is the most important event in individual's life, and it is the union not only of two individuals, but we have to understand it is the two lives coming together. It is about the best possible thing you can get out of the relationship is that you are with someone who encourages you to be the best version of yourself every day. Unfortunately, till for a long, maybe in this decade, the things are changing. But if you see overall, it is the Kundli, which is the matching, whether it is a love marriage or whether it is a family gala. What is completely neglected is the sexual counseling of it. When the individual get married, the whole family is preparing to welcome the new member. The couple starts getting many advices, everything under the sun, from the children to the house to the finances. But no mother or no father, no family member sits and discuss with them, the girl. Just imagine a girl from a village. She doesn't know, non-medical girl, what the sexual relationship is. No one explains to her before the marriage. I have, you know, my own family who have, I can't tell you who are they, obviously, but very close family friend, their son and the daughter-in-law who had gone for a honeymoon to an international place for 3 weeks, came back, and after 10 days, they took my appointment. I thought probably honeymoon cystitis, but the thing is how to have sex. That was their issue. This was just 10 years ago. Though they did not see the Google, probably now in these 2 years, the things may change. What is premarital sex counseling? This is form of a counseling which aims at educating the partner on their journey before marriage and help them with all the answers, the questions that might have in their mind, and they are, especially in arranged marriage, where the lady is shy to talk with the guy and this vice versa. It is therapy for both the parties, which aim at helping them to grow in their intimacy and connect to themselves on a deeper level. So it includes generalized counseling, medical counseling, genetic counseling, sex education and sexual counseling, and also the nutritional and healthy lifestyle counseling. So what is this sexual counseling? The therapy where one is sexuality, sexual concern, and all the problems are discussed by the counselor. If you see a decade ago, there are so less sexual consultants in the country, and whoever are there, they are roaring practice. That is because it is silently counseled. It is still taken as the thing which we should not be going. Only those who are idiots, they need this counseling, is the myth which unfortunately many couples face. What is the central issue in relationship? The sooner a couple can start having healthy communication about their sexuality and about their expectation, many a time the lady doesn't know also, she also should be expecting in the relationship. Sooner they will find harmony in their lives together. So you should not be thinking twice before you a marriage date. Go sit with the counselor and ask each and everything about it. Now, what are the various reasons? As I discussed earlier, there are many misconceptions and the fears. There are many myths. One is masturbation is wrong and cause sexual dysfunction. Sexual penetration is painful. The lady has this. And we all know someone is talking. Mandakini, can you mute yourself?
1 minute, 1 minute, 1 minute.
Thank you. So sexual penetration is a painful, and that's the reason why there can be vaginismus. Every one of you who are in there, more than 10, in their private practice. See, last week, a high profile, they are the dancers in the film industry, near 36, 37 age group, married for 10 years, not had a single time sex because the girl is so stressed about the painful thinking. I have to literally make her lie down, put Xylocaine 2% for 5 minutes, and then I told her, I'm putting this vaginal probe. She got scared. I told her, don't be scared. And it went on so easily. So the fear has to come out, and that's a myth many people have it. Moreover, sex education is not provided in the schools, and the lack of it creates a gap between the knowledge and the misinformation. Unfortunately, this is very true in India. Couples, especially women who will be engaging in sex for the first time, should not feel scared about the activity. Sex counseling can do away with all such misconceptions and clear many doubts with them. Awareness. Often couples fail to communicate properly about their desires and fantasies surrounding the sex. It is very important that both the couple equally should be open about them, about what are their myths, what are their expectations, and the lady also should be respected equally. Talking in front of a sex counselor will help the couple to discuss everything about it, ranging from the frequency to compatibility. Sex counselor can help them in opening up the dialogue between the partners. Talk about likes and dislikes concerning the foreplay, orgasm, and other key parts of the sexual intercourse. This is very, very important. Unfortunately, in India, 70% of the males still believe that it is only the male partner who needs to reach the orgasm, and it's an unfortunate thing. Third most important thing is planning the pregnancy. Women often get confused when it comes to their menstrual cycle and pregnancy. Many a times they want to just plan the safe period and unsafe period, which is the most unsafe method of contraception. And what happens is they don't know what is the first day of a menstrual cycle, which is the 7th day of a menstrual cycle, and that can result into unprotected sex and unwanted pregnancy. Pre-pregnancy planning, this premarital sexual counseling also involves the counseling of the contraception in a very huge way. Counseling helps them to understand how the ovulation happens, how the pregnancy happens, what are the various contraceptions available and which they can take, the male partner, the female partner, and what is the success and the failure rate of that. Because both the couple have to agree with each other what contraception they want to adopt if they don't want to plan the pregnancy earliest. Many a time, sexually transmitted diseases. They don't understand the basics of HIV or other sexually transmitted diseases, even simple candidiasis. They don't know that you can transmit this fungal infection also through the sex, and they will not, many a times they don't even know how to use the condom properly, leading to unanticipated and unwanted circumstances. Pre-marriage counseling will help the couple to have the knowledge about everything. These sexually transmitted diseases, syphilis, hepatitis B, HPV, gonorrhea, HIV, and to me, I will say even the fungal infections. It's very important that they should be having a knowledge about it. Many of them have a first night failure, and then they get frustrated because they had the fantasy, they had the lot of the things they have read about the first night, and due to various misconception and misinformation, they may fail to have an intercourse just immediately. And that may lead to sexual disharmony, frustration, sexual disorders, and disturb family life, and may reach to the divorce. So premarital sexual counseling will definitely help them to overcome this first night failure. Absolutely. Components of premarital sexual counseling. What does the counselor they take? In a short, of course, I can't cover everything, but what is most important thing they will talk about is interaction with the opposite sex. What are the sexual risk factors, sexual protection, sex education, and sexual vulnerability. They will talk about all these things in detail with all. Now, also forget about the misconception about the sex. Many have misconception about the premarital sex counseling only. Who should be attending? And they feel that it is only for the bad time. You are not supposed to go to the counselor unless you phrase the problem. That is the biggest myth people have. It is only for the bad times. Example, when there is an unwanted pregnancy which has come, or unhealthy sexual attachment, any other problems related to sex come, then only they are supposed to visit the doctor or the counselor. Counseling can be done even when everything is going well, and it is meant to educate the couple and shield them from doing what is wrong, has to be spoken very high. Also, this is an absolute misconception that it is needed only for those weak and who are not so smart. If you go, it shows that you are not smart, you are not educated. That's such a bad misconception. And it is very important that everyone should at least visit. If they don't, they are not medicos or in the nursing, I feel so. Another myth is that most effective way to learn about each other is through the sex. Actually, life after marriage will not revolve only with the sex, but there are other things that they have to work around. So if it's going great, it's fantastic. But if not, take the help of a counselor. That's a misnomer. They should go sit together and talk about it more openly. So friends, premarital sexual counseling helps the partner to figure out the blind spots which are there in their mind, the misconceptions, and then they correct them. It will help the couple to communicate their needs and ideas effectively, especially the female partner also will be respected and will be taken care of from the day one. It gives information about the dangers of a premarital sex, unwanted pregnancies, STDs, unhealthy sexual attachment, and others. So it's very important that these all should be communicated very well. Friends, I'm going for a FOGSI presidential activity. Elections, they are going to be in August 2023. From 1st August to 10th August, I humbly request your blessings from all of you. Thank you so much for giving me an opportunity. This was such a simplified topic, and I feel so that those who are there, their daughters, the son, they are getting married. Probably you may not be able to sit or they may not come to you, but ensure that you tell them, go to the counselor, sit with them, discuss both of you, and come out of the room from the counselor very happily, so that you have not only the happy married life, but happy sexual married life, where you can concentrate on other needs of the lives beyond it also. Thank you.
Thank you, Sunita. It was a comprehensive, informative talk, and you covered all the aspects of premarital sexual counseling. That was the right word, because when we say premarital counseling, it has other different components as well. So your talk was very, very focused, and it was pertaining to our course on sexual health. Thank you, dear, for sparing your valuable time and addressing our delegates on this very important topic on sexual health. Thank you, dear.
Thank you. Thank you for adjusting me a little bit ahead. Thank you.
Thank you, Sunita madam, for joining.
Thank you, Neeraj. Apurva, big thank you.
Thank you so much.
Thank you, and I wish you all the best.
Thank you, ma'am, for
Thank you,
such an
ma'am. Thank you
enlightening
so
talk.
much, ma'am.
Thank you.
Thank you.
Queen,
Dr.
yeah.
Koya,
Yes. Yes, thank you so much. Now we move to the next topic that we'll be hearing about the sexual anatomy and physiology of males and females. And the topic will be taken up by Dr. S.S. Vasan. We are really privileged to have a uroandrologist amongst us today. He is from Bangalore, and thank you so much, sir. Please, it's all yours. Dr. Vasan, please.
Yeah. Can you hear me?
Yes.
Yes, sir. Yes,
Yeah.
sir.
Thank you very much for this invitation by the sexual committee of the FOGSI. I'll just take you through the anatomical significance and possibly a little bit of physiology of the male and the female. We are going to cover, these are the areas which we are going to cover, which is the sexual anatomy in the male, female sexual cycle. Of course, there's a big talk, but I'm going to limit to certain aspects of it, and physiological aspects of male and female. Now, we all know that in the male, the sexual apparatus consists of a primary sex organ, which is the testis, and the reproductive tract, which is made out of epididymis, vas deferens, spermatic cord, and the urethra. And you had accessory sex glands in the form of seminal vesicles, prostate, bulbourethral glands, and then you have the penis. This is the broad male sexual apparatus or the reproductive apparatus. Now, most people believe that penis is the most important organ, but however, it's basically involved in sexual intercourse as an both as an excretory as an organ which gets hard during an erection, as well as an excretory organ, because it's excretory because it transmits urine and seminal fluid, as well as it has the function of because of the urethra, and it also because of the corporal bodies and the corpus cavernosum, it has the function of the erectile apparatus, as we call it. So consequently, we need to realize that penis is a complex structure where there's an erectile tissue which is made out of corpora cavernosa, as we call it, bilateral, which is two in number, and the urethra, which is surrounded by spongiosa. So there is two corpora cavernosa, and then you have a spongiosa, and posteriorly the corpora cavernosa diverge. This is the corpora cavernosa, as you can see, and posteriorly they diverge, and this divergence is called the crura, and that is anchored to the ischial ramus of the pelvic bone. So this is where it is anchored, and that is very important. And also the corpora cavernosa, there is a bulb at the end of the corpora cavernosa, which is called the glans, which is primarily made out of the spongiosa. There is no corporal element here. Corpora cavernosa end inside the spongiosa. So you have the spongiosa which creates the glands and not the corpora cavernosa. And of course, you can have the skin component, which is this one. So that is the broad anatomy of the corpora cavernosa. And on top of that, you have the blood supply and the drainage. Basically, the blood supply is through the dorsal artery, which is the principal artery, and you have the cavernosal artery. and which supply both the corpora cavernosum, glans penis, as well as the corpus spongiosum. And there are multiple branches in terms of anterior branch, bulbourethral artery, and so on and so forth. So this is the broad anatomy of the corporal bodies. And these corporal bodies, because they are something like a lung tissue, which is like an alveolar tissue, these tissues also resemble similarly. So they are supported by what is a very strong facial tissue called tunica albuginea, and tunica albuginea is the one which protects the penis from any sort of injury which can happen, especially because penis is a blood-filled structure. So then you have the prostatic urethra, which is a longitudinal crest which opens into. I'm just going to skip some of this, is not relevant for the sexual anatomy part of it because it's more relevant. But what is relevant is that the accessory glands, which are 3 in number, which is your seminal vesicle, you have the prostate, and you have the bulbourethral or Cooper's glands, which essentially not only secrete seminal fluid, they also are important for protecting the sperms, as well as they create lubrication of the urethra, which is very important because the seminal fluid comes separately and urine comes separately because of the independent bladder neck closure, which is very, very important. So this is what is the structure. And so as you can see in this sagittal section and the coronal section and the horizontal section, the testis, the seminal vesicles are located next to the prostate. This is where the seminal vesicles are located, next to the prostate, and the seminal vesicle discharges into the ejaculatory duct. And so the entire erectile apparatus consists of corpora cavernosa, which is in the penis, spongiosa, which is in the penis. Then you have the vas deferens and the seminal vesicle, which are in the retroperitoneal area, and then they are interconnected because of the discharge. Similarly, in the female, if you look at it, you have the mons pubis, you have the clitoral hood, you have the clitoris, and then you have the outer lips and inner lips and all that, and then you have the perineum. And then I'm sure all of you are aware of the female anatomical significance of the sexual apparatus. Now, in the female, the most sensitive organ or important organ in a female sexual response is the clitoris. And the clitoris is made up of glans clitoris, clitoris shaft, and again, because it's a representation of the penis, it has a corpus cavernosum, which is represented. It has a bulb and the vestibule, and it has a crura of the clitoris. Similar analogy to the male. So the glans knob of the tissue externally in front of the vaginal opening and the urethral opening is the glans clitoris. And like I said, it consists of 2 shafts and similar in nature to the penis. So the clitoris is the erectile tissue in the female, and this is the erectile tissue. It is because it contains blood vessels which fill it with blood, and also it is innervated, and it has extreme number of innervation and full of free nerve endings, which are called cross finger corpuscles or corpuscles of Pacini and Meissner, which are present in the clitoris, which gives it a very high sensitivity, and consequently, we all know that many women are clitorally orgasmic and may not be orgasmic through vaginal penetration. Then there is this talk about important sexual point in the female. There are various spots in the female which are designed with the O spot, which is 2 to 4 centimeter below the posterior fornix between the posterior vaginal wall and the rectum. A spot, which is 2 to 3.5 centimeters below the anterior fornix under the bladder wall on the anterior vaginal wall. G spot, which is the Grafenberg spot, which is 2.5 to 4 centimeter under the mid urethral length on the anterior vaginal wall. U spot, which is the Morris point, and which is the area of the urethral opening. So the most important of this, which is hypothesized to be very significant, is supposed to be the G spot, which a lot of people believe if you stimulate would lead to an orgasm in women, in certain women, but not all women. So this is the broad look of the female reproductive tract and in terms of its sexual pathway. Now, when you understand anatomy, you have to correlate it with physiology. Now, whenever you have a male sexual pathway, you need stimulation, and the stimulation, which is through the central pathway, is both for erection as well as ejaculation. That means ejaculation and expulsion should happen at the same time, and that is needed in order to achieve an erection and an ejaculation. The stimulation is usually both in terms of afferent pathway. You have the pudendal nerve, which supply the penis, which is the somatic pathway, and you have the free nerve endings which are present in the corpora cavernosa as well as in the skin of the penis. And then you have the parasympathetic, which is the S2 to 3, 4, S2, S3, S4 pathway, which is carried through by the pelvic splanchnic nerve and through the preaortic and prostatic plexus. What does it does? It causes release of nitric oxide, causing vasodilatation of the deep arteries. So the dilatation or the erection is controlled by parasympathetic. The detumescence is controlled by sympathetic, and that is the phenomena which happens in the penis. And this is basically triggered. I will show you this video. I put down this video just for you to have an understanding that you need a central pathway which the arousal mechanism should happen, and consequent to that arousal mechanism, you have dilatation of the arteries, and once there is a dilatation of the arteries, then there is an increase in the blood flow, and that compresses the venules, so that the tunica albuginea and the corpora cavernosa, the emissary veins which are present, gets compressed, so the blood gets trapped in the corpora cavernosa, creating a rigid erection till the emission happens. And once the emission happens, the sympathetic activity overtakes and there is a detumescence, and again the space between the tunica and the corpora cavernosa increases, so the emissary veins open up, and that is how it comes. So this is triggered by various phenomena. Tactile phenomena, you could have a tactile phenomena which causes an erection, and because of the contraction of the bulbocavernosus and ischiocavernosus. So this is called as a bulbocavernosus reflex. So there are not, sometimes you can avoid the central stimulus. That's how masturbation works. Many a times you may or may not have erotic activity, but you could bypass the erotic activity and have a masturbatory reflex erection, which is created because of tactile stimulation. So these are all very important elements of an erection process, and I'm going to skip this. So additional to this, other than the sympathetic, at the terminal nerve endings, this is a little complex. I don't know whether it is necessary for you at this stage, but there is nitric oxide, cyclic GMP and GMP pathway, which ensures that there is a minimal amount of nitric oxide which is required, and cyclic GMP pathway is triggered, and it prevents most of the drugs which we use is preventing cyclic GMP breakdown to cyclic AMP, and consequently the vasodilatation persists, and that's how an erection is maintained in any of these ways. So this is the phases of male sexual pathway, where you have sympathetic activity, parasympathetic activity, emission. Emission is controlled by T10 to T12 to L2, and wherein the phase 1 of the emission, the seminal vesicle and vas deferens contract and deposit semen in the posterior urethra. In the phase 2 of the emission, there's bladder neck closure, prevention of retrograde ejaculation, and so on and so forth. And then you have the phase 3 of the emission, which means that the semen has to come out, which is the rhythmic contraction of the bulbocavernosal and ischiocavernosal, which causes the propulsion of the semen to come out outside. So this is a complex interplay. If you look at it, it's a very complex interplay of sympathetic, parasympathetic, central nervous system, lumbar plexus, and the terminal nerve fibers, and then you have the physiological process of the somatic and sympathetic and parasympathetic, as well as the neurotransmitters, which are very essential to create an erection, to cause an ejaculation, and then cause an emission. Now, when you look at the female sexual pathway, this is a 4-nerve-6 pathway theory of female orgasm, wherein you have the glans clitoris, some parts of the clitoral complex, which is basically the pudendal nerve, goes through the sacral plexus, and you have an orgasmic phenomena there. You could have a clitoral orgasm. Then you have the vaginal stimulation, anal stimulation, some parts of clitoral complex, deep vaginal erogenous zones, G spot, A spot, O spot, pelvic floor muscle contraction, which are initiated by pelvic nerve, hypogastric nerve, vagus nerve, and then intercostal nerves, which cause the nipples. So there are a lot of things which are, I don't think I can cover all this in a detail in 15 minutes of both male and female, because female is much more complex, because there is eroticity created by the breast, there is eroticity created by the clitoris, there is a eroticity created by the touch of the female, especially the neck part, the side of the waist part. So that's where intercostal nerves, which trigger the oxytocin pathway, and then it contributes to the brain, and that constitutes to vaginal orgasm and clitoral orgasm. So this is a very complex pathway. That's why female orgasm is multifactorial. Penis is one organ, whereas in females there are various ways you can trigger an orgasm in a female. So consequently, this is what I think Dr. Sunita Tandulkar was talking about in terms of sexual education. Sexual education is not about how to have sex. Sexual education is to understand that there are women who are stimulated by certain pathways, and you need to be aware of that. So this is my 15-minute brief where I was given to talk about male sexual anatomy and female sexual anatomy, and hopefully I have covered this topic to the satisfaction of the ICOG committee. Thank you very much.
Thank you,
Thank
Dr.
you very much.
Vasan. It was really informative, and what we could understand is that it's really very, very complex as far as this male orgasm and female orgasm is concerned. Thank you so much. And I can see our Dr. Mandakini Meg, who is still waiting. Dr. Meg, are you with me?
Yeah. I'm here.
Yeah,
Very
so
good.
yeah, please, I invite you for your comments. Yeah.
I think excellent lecture given by our doctor, our expert, and most importantly, what he has said, that is female orgasm is such a difficult, and female physiology, to understand female physiology through so many interconnected G spot, other stimulations and all these things, including the male sexual pathway. To understand this, all our gynecologists, I think, in this course are really, it was extremely, informative. And I think we should look into that particular, I think, orgasm, which is very important for the sex. So I think, thank you, Lakshmi, for that, inviting me as giving some comments. And they are the specialists, we are all the specialists, and we are learning from them. And we are focusing on the orgasm, female sexual pathways, male sexual, focusing on this particular subject. So thank you very much. And if you permit me, then I can just share the slide. So friends, sorry to interrupt, but I really want to say that I am contesting for the post of President FOGSI. I was chairperson ICOG, who actually initiated all these courses, online courses. And today you can see these courses are being taken up by Lakshmi and everybody, Parag Binniwale, all this to a greater heights. I'm extremely happy to do excellent work into the ICOG and so many of journal club, that ICOG certificate courses, other reproductive medicine, all the courses are being, carried out with all the zest and enthusiasm. I'm extremely thankful to the present chairperson, Dr. Lakshmi, and all the office bearer. And I
Thank you, Vasan sir.
Thank you.
Thank you, Vasan sir.
That you are not a FOGSI member, ICOG member, Dr. Vasan, but still then you have spared your valuable time to speak on such a complex topic to educate our FOGSI ICOG members. Thank you on behalf of all of our ICOG team. Thank you so much.
Thank
Yes,
you.
I was a little bit hesitant when I included anatomy because I thought what we will learn about anatomy. But
That is the foundation, Neeraj.
Thank you very much.
Yes, thank you, Dr.
So
Vasan.
many points now we have not aware about that.
It was a wonderful session. Everyone has enjoyed it thoroughly, and we've learned so much. And the pictorial demonstration it has made an impact. Thank you so much.
Thank you.
I would invite Dilpreet now to carry it forward.
So carrying forward the program, next talk is by Dr. Atmik Jain on sexual response cycle. Dr. Atmik has done psychosexual medicine training fellowship from India as well as from European school, and he's working as a sexual health counselor in various hospitals of Indore. I welcome you, Dr. Atmik Jain, for the next talk.
Okay, thank you so much, ma'am. Thank you so much for the warm welcome. Good evening, everyone. I'm Dr. Atmik Jain. I practice sexual medicine exclusively in Indore, Madhya Pradesh. First of all, I would like to thank Dr. Neeraj Jadhav sir and the office bearers to give me this opportunity to present on such a big platform. Then it gives me immense pleasure to present in front of you sexual response cycle. Now, the question is why there is a need to learn about sexual response cycle, because here lies the devil. The devil of secrecy lies here, which tries to maintain its character. Even when we are trying to, we do not know what is happening behind the closed doors. And even if we try to inquire more on this by blood tests or body scans or even a detailed history, we usually fail. So in order to understand this devil better, we need to know how this whole process works. Okay, so we'll start with the today's presentation. Is it visible?
Can we get full screen, Atmik?
Yes, sir. Yes, ma'am.
Yes, correct.
Yeah, just a moment, ma'am, please.
Yeah, it is full screen now.
Okay, so sexual response cycle. So sexual response is a series of events, series of changes, both physical and psychological, that take place when a person is sexually aroused and takes part in sexual activities, that is intercourse and masturbation. Now, this helps in understanding of various physiological changes which occur during a human sexual response and its dysfunctions in a systematic manner. So understanding all these factors helps in exploring our own sexuality and helps understand our partners, helping understand our partners, our bodies and other bodies, and enhance the sexual experiences. Now, as we can see here that both men and women experiences sexual responses, but the timings are different. The timing of the timing spent in a particular phase is different, and the intensity also differs from person to person. As we can see here that the phases are different for male and female. The male escalates too quickly, and the female have to take stairs or have to take a longer pathway in order to reach sexual satisfaction. Now, there are many models given, but they are given in either in a linear form or a circular form. The linear models were given by Moll, the EPOR model given by Master and Johnson, the DER model which was given by Kaplan, and then there are circular models which were given by Basins, and sexual tipping point model given by Perelman. Now, the first model was given by Moore, which was a very simple model, which actually mentioned about the 4 phases, that is the onset, the equable voluptuous sensation, that is the sexual attraction or the sexual sensation, the voluptuous acme, that means the highest point developed, and the sudden diminution of sensation might be orgasm, and after that resolution. Now, the drawback of this model was that it was very non-specific and it involved the basic structures of the body, and so it was applicable for both males and the females. Another model was given by Havelock Ellis, which was based on the anatomical findings, and it has only 2 phases, tumescence and detumescence, means swelling of the genital tissue and resolution to the baseline. And this model had poor explanation of the facts, that's why it was an incomplete model. Then came Reach. Reach was a pupil of Freud and described a process which is known as forepleasure, now which is called as a foreplay, which is followed by 5 phases, that is penile penetration, voluntary control of excitation, involuntary control of muscle contractions, sudden and steep ascent to the climax, and orgasm. And he decided that all these processes usually take place in a duration of 5 to 20 minutes. Now, then came the masters of Sex, Master and Johnson. So Master and Johnson gave the EPOR model, which contained 4 stages, that is the excitation, plateau, orgasm, and resolution. And that was based on the physiological and observational studies. We all know that they have done a lot of work in understanding sexual response cycle and what usually happens. And they set up an observatory also. They used to see people having intercourse, and then they have different models and even different equipments to measure all these changes. Now, first is the excitation, the excitement phase. There is increased blood circulation in the pelvic area. Then the plateau phase, all the changes which happened in the excitation phases now has intensified, and there is increased stimulation and muscle tension. Then came the orgasm. There is a muscle contraction in the lower pelvic area. Then the resolution part. This happens after orgasm, and in males it is seen that there is a phenomenon called as post-ejaculation refractory period, and in which after orgasm, after ejaculation, they take time to achieve erection or orgasm for a certain period of time. And in some females with urethral emission, we have seen that after the orgasm has achieved, this post-ejaculation refractory period is seen, but in very few females. Now, the drawback of this model was there was a strong genital focus and there was no mention of the desire in the whole sexual activity. Then came Helen Singer Kaplan. She gave the DEOR model. Here she mentioned about an excitation phase where a person feels the need to undertake the sexual activity, and this was the desire phase. The DEOR model stands for desire, excitation, orgasm, and resolution. And here what she did was the excitation phase in this model combined the excitation and plateau of the EPOR model. So this is a modified EPOR model, that is the DEOR model by Kaplan. Then came the circular model, that is by Rosemary Basin, the biopsychosocial model. So this model has 3 main features. That is, this model explains sexual functioning in women in long-standing relationship. In these women, the desire phase may not always be present before sexual activity. The desire comes afterwards also, after an initiation. So they may start with a position of neutrality and subsequent sexual stimulation activates desire. Now, providing that this complex state of arousal is accompanied by positive emotions and thoughts, then the arousal increases in intensity and then triggers sexual desire, and the arousal and desire then coexist and reinforce each other. As you can see here in the cycle, it starts with sexual neutrality, then there could be a stimulus which leads to arousal first, then the desire develops, and then satisfaction, emotional intimacy becomes strong, and then there is a phase of sexual neutrality. So specifically in females, we have seen that sexual response is more often governed by closeness and attachment and may significantly augment and enhance sexual response in a circular reinforcing manner. So this flowchart is more specific. So we can see here that there are multiple reasons for sex, which we call as a motivation, which leads to deliberate attention to sexual stimuli provided by the partner, and initial spontaneous sexual desire, which leads to a sexual stimuli. Then add-on are the biological factors, the psychological factors, and the initial desires, which leads to processing of the information in the mind, leading to subjective arousal, and more desire is triggered, which leads to a sexual satisfaction, and original goals are fulfilled, means the intimacy has increased, and which adds on to the multiple reasons for sex or the sexual motivations. Now, imaging techniques and more research have emphasized on the circular model and has expanded on the influence of psychological, biological, and socio-cultural factors within a complex network of components. Then comes the sexual tipping point model. So according to this model, there should be a balance between excitatory and inhibitory factors, which will lead to a satisfactory sexual intercourse. So sexual tipping point model proposed by Perelman suggests that sexual response is determined by balance between excitatory or inhibitory factors that may be psychological, organic, psychosocial, or cultural. Now, the combined effect of these factors result in a unique threshold or sexual tipping point, which determines whether a sexual response is expressed or not. Means if all these factors, all the excitatory factors are in a perfect balance, then it leads to formation of a threshold. And then if we cross the threshold, we reach the desire part, and then slightly we move on to the other phases of sexual response. The specific threshold for the sexual response is determined by multiple factors for any given moment or circumstance. Means the time is very important here. And even according to the circumstances, the factors may vary, with one factor or another dominating while others recede in importance. So as you can see here, that there should be a balance between all the excitatory and inhibitory factors. Whichever side is heavier, that leads to a sexual expression. Now, that could be a positive sexual expression also, or a negative sexual expression. Now, moving on to the physiological changes in different phases. We have read all the models, but if we take the DEOR model as a basic model, then what is actually happening in all these phases, what the person is feeling mentally and physically. So, excitation. As you can see here, I have labeled the boxes in colors for males and females, whatever physiological changes are different, and the yellow box is for the common physiological changes. So in males, we can see the tightening and lifting of the scrotal sac, increase in size of the testis, contraction of the facial, abdominal, intercostal muscles, and erection of the penis. And in females, there is increased diameter of the glans and shaft, labia majora elevates and flattens, vagina elongates for penile containment, and color changes to dark purple, and the uterus ascends to false pelvis, and labor-like contractions occur. Now, what is common is flush in the abdomen and the anterior chest wall, nipple erection, raised heart rate, blood pressure, and respiration. Now, the orgasm part. If we talk about the male part, then flush is common here. Ejaculation is occurring now. So, the 3 or 4 contractions of vas, seminal vesicles, and prostate, and systemic contractions of the rectal sphincter occurs in males. Raised heart rate, blood pressure, and respiration. And this is accompanied by a sudden euphoric sensation and a release of sexual tension. This usually happens after ejaculation. So here I would like to mention one thing, that ejaculation and orgasm are 2 different processes which occur simultaneously. Okay, this is not a single process. And whenever we are in our OPD, there are a lot of male patients, young patients, who tell us that who complain us about the weakness or the dullness after ejaculation. They say that, sir, after ejaculation, masturbation, or sex, we feel very dull. So we have to explain them that there is a certain euphoric sensation and release of sexual tension, which should not be just confused by a dullness or the sleepiness which we follow after ejaculation. Now, if we talk about the females, flush is there, breast becomes tremulous, contractions of lower third of the vagina, that is uterus and the rectal sphincter, and raised heart rate, blood pressure, and respiration. Now, females have this facility of multiple orgasms, that is before multiple orgasms, and it happens only before the arousal drops below the plateau level. More commonly after masturbation, it is seen, and depends on the continued interest in sex and stimulation. So if they still want more, they are actually focusing on the act, and the stimulation is very proper and very precise, then multiple orgasms can occur. And other factors are nature of sexual fantasy, what she's thinking at that time, ease of continuation of stimulation. If it is happening very clearly and very easily, then it leads to multiple orgasms. And lack of distractions of partner are some of the other factors. If the partner is not distracted, if he's done and he's still trying to stimulate his partner, then female can reach to other orgasms. Now, what happens in the resolution phase? Resolution, the flush disappears. There is inconsistent.
Only
Yes,
1 minute left. Kindly be fast.
Ma'am, last few slides. Thank you so much. Yeah. So flush disappears. Testicular scrotal descent is there. erection goes away, that is partially in 5 to 7 seconds and fully in 5 to 30 minutes. Penile detumescence occurs followed by post-orgasmic refractory period, which we have discussed earlier. Now, the flush disappears in reverse order in females. Inconsistent perspiration, clitoris returns to normal position, and uterus, the contraction ceases and returns to its normal position. Now, as Vasan sir has discussed very clearly and has mentioned the hormonal aspects, I would like to brief the hormonal aspects very quickly. Like testosterone increases the sexual interest, prolactin diminishes the sexual interest. In women, estrogen and androgens are involved in sexual arousal, and orgasm is led by prolactin, luteinizing hormone, and oxytocins. Now, there are some factors which actually influence the sexual response cycle. One is the stimulation. That is a type of stimulation, adequacy, site, and continuity of the stimulation. Site is very important. All the females should know what are their pleasure points, and they should convey this to their partner. So site is very important. Then state of mind of both the partners, receptivity of the partner, age. So age here is a bidimensional thing. Sometimes with increasing age, the sexual desire increases instead of decreasing. So this could be because of the ease of sex, the privacy, and the improvement in quality of life. Then chronic physical illness, medications, and other psychosocial factors. Now, what is the effect of aging on males and females in different phases? So in excitation phase, erection is disturbed, difficulty in sustaining erection. Plateau phase, the erections are loose and the testis does not elevate as much as in younger time. Orgasm phase, number of contractions reduced, pressure of ejaculation is reduced, and the resolution phase is erection becomes flaccid faster and the refractory period is longer. And in females, the excitation phase is reduced, there is reduced lubrication. The vagina does not expand as much as it used to earlier for vagina penile containment. Plateau phase, older females take more stimulation to get aroused and stay aroused. Orgasmic phase, muscle contractions may be fewer, leading to less intense orgasm. And resolution phase, that body may take less time to return to the neutral state. Now, there are some disorders of sexual response cycle which has been discussed very clearly by Dr. Malhotra sir.
Dr. Atmik, may we have the conclusion remarks, please?
Ma'am, this is the last slide.
No, Dr. Atmik, please continue. Please continue.
Okay, thank you so much. So there are some disorders which are both common in both males and females, and some different in both males and females. So desire disorders in males is less desire in males and females for sexual intercourse. They are unable to respond to sexual intercourse, sexual hints given by their partners. There is sexual aversion disorder, that is avoidance towards sex. Erectile disorder, which is difficulty in maintaining erection, getting loose erection or delayed erections. Arousal disorders, this could be because of lubricating issues. Premature ejaculation, patient is unable to hold an ejaculation and there is severe distress. And the delayed ejaculation, patient is trying his level best to ejaculate but is unable to ejaculate. Now, female orgasmic disorder, this could be since the beginning that never experienced orgasm, or it happened later in life. Then postcoital dysphoria means there was post-orgasm or post-sexual activity, there was a dullness, sexual frustration, depression in both the partners, male or female, and post-coital headache, that is experiencing headache post-ejaculation or post-orgasm. So these are the references. Thank you. Thank you so much.
Thank you so much, Dr. Atmik. And if you can just go through the chat box, there are 2 questions related to your talk. So please answer those queries before you leave. Yeah.
Ma'am,
Thank you. It was a great talk and extremely sorry to keep you interrupting.
Sorry, ma'am.
There are 2 queries. First one is that husbands can masturbate to produce the semen sample, but they are not able to have sex. Why?
So, ma'am, this actually usually happens before because it has been seen that males who masturbate very frequently before their first sexual activity or before marriage, they are very much comfortable with the hand grip. So they find it difficult to ejaculate while having penetrative sex with any of the partners. So this could be the main reason behind this.
And the reason for headache after intercourse.
Ma'am, there are many neurological and physiological factors which can lead to headache post orgasm that needs to be discussed in detail. So I can actually, if you want me, I can explain them personally after this session.
You can put up in the chat box.
Yeah,
You
you
can,
can in the chat box, and Atmik, I really appreciate. Thank you so much for sparing your valuable topic, valuable time and covering in detail such a complex topic. So thank you so much on
Thank you,
behalf
ma'am.
of
Thank you.
ICOG. Thank you.
Thank you so much, ma'am. Pleasure is all mine.
Can you
Thank you so
stop
much.
sharing?
Thank you, sir. Sure, sir.
Yeah.
Dr. Queen, please. Thanks.
Yeah, exactly. Thank you. So now we call our next speaker. Can we have the
Yeah, one minute.
Dr. Vijay Ramanathan? We would like to invite Dr. Vijay
Yeah, 1
Ramanathan.
minute.
Welcome, Dr. Vijay. He has logged in from Sydney, and we
Yes,
really
yes.
value your time and efforts to teach our delegates. Welcome to India, though virtually. We welcome you on this platform of ICOG.
One more thing, Lakshmi madam, it's very late in Australia, but sir
Yes,
has
it's
agreed
10
to
p.m. I think it's
be
10
part
p.m.
of this
already.
because it is very inconvenient time for sir.
No,
It's
But still he has agreed to. So
Yeah.
Dr. Vijay Ramanathan is a clinical sexologist, and he is in the Sydney University currently as a faculty, and he has logged in from Sydney. Thank you so much, sir, and welcome.
Thank you. All right, let me share my screen.
yes.
All right, and please tell me if you can see it.
Yeah.
Yes, sir.
Make it full screen.
Is it full screen now?
Great, great,
It
great.
is. It is.
Yes, sir.
Right.
All right, so that's the most prestigious university in Australia, the Sydney University, where we get graduated. So I've been there 4 times to be graduated. So thank you, Dr. Neeraj, and to the committee for having me as part of this wonderful workshop. So now I would like to check with the timing. So I've been allocated 30 minutes. Am I right, Dr. Lakshmi?
Yes.
Yep. All right. So I'll keep myself a reminder because I hate to go over time. So I will get started. Right. So
Sorry,
that's
sir,
about
our
me.
moderator will remind you. Don't worry about that.
Okay, there is someone talking
No,
through,
no,
but that's all.
Please start, yeah.
All right. So I have about 15 years of academic practitioner experience. So I have a dual role, a consultant in sexual medicine, and I also an accredited psychosexual therapist. So these are my affiliations, and I declared no conflict of interest in doing this presentation today. And my materials are copyrighted. All right, so it's a very important topic, and I just want to make some observations and commentary from the previous talks. And one thing I heard, there is this notion, men's sexual response, men sexuality is very simple, it's one button, whereas female sexuality is very complex, multiple. I think that's a very simplistic view, and I would like to disagree with that. So it's complex. Sexuality is complex in anybody. And also that notion that men are linear and women are more circular, that is once again needs to be taken with a pinch of salt. Not all men are linear at all times. Not all women are circular at all times. And the other thing is, in 2023, we are still talking very much male-female. So I think it's also important to understand there are people who don't necessarily classify themselves as men and women. So anyway, sexual history is very important because unlike in other specialties where there are so many investigations and intrusive investigations, in sexual health, sexual medicine, clinical sexology, we rely a lot on history. So with history is everything, and history is not just collecting some random information, and history taking is not necessarily just filling out
a particular tool. So that's something I want to put it across very clearly at the very beginning, because I do hear that people use the IIEF or they use some other tools. They quickly go through it and come and rely solely on it for diagnosis. It is a great adjunct. It's good to have some measures, but we cannot rely just on that to have a diagnosis. So why sexual history? So this is very important, and I've kept my slides very simple and easy to read and understand. Now, history taking, when we are communicating with our patients, in the process of history taking, we are actually establishing rapport and trust. Because if somebody tells me that they can take sexual history in 10 minutes, I really need to be convinced after being in this field for 17 years, how is that possible on earth? Okay, it takes a while for patients to build that rapport and trust, but I do understand gynecologists, you don't have the same time as I do. That's understandable, but making things very quick, just tokenistic questions and asking one and jumping into a conclusion, I think there is a risk of doing harm than any benefit. So establishing rapport and trust is very important. The second section of my talk would be how sexual history helps us in understanding the person, the problem, and the context. Now, without the three, it does not make sense. You cannot just treat a problem, because the same problem could be different to different person at different stage in life. And there are so many contextual factors that we need to take into consideration. The third section, we look into some case formulation. And finally, how sexual history can be roped into education and for further management of the client. Now, one good news is I am free. I believe in sharing knowledge. I don't believe in keeping it to me. Dr. Neeraj knows very well. I'm willing to share my pro forma, and please feel free to distribute. And those who need, you can always contact me directly as well. That pro forma, you can use it in a way that you want it. So it has a complete sexual history pro forma. All right. Now, it's the most important thing is do not jump straight into asking questions when the patient just comments. Don't shoot questions straight away. I have learned it in a wrong way. I asked questions to one of my patients many years ago. And somewhere through the questioning process, the patient started thinking, oh my God, why are you asking all these questions to me? Do I look in a particular way? What made you to ask these questions? Now, the patient does not know that I'm asking the same sort of questions to all my patients, whereas I know that I go through a set of questions with all my patients. So it's important to give some sort of priming to the patients, okay? So the reasons for asking these questions is not to judge you, but mainly to help you. So that needs to come across very clearly, because some of the questions, the way we ask could come very judgmental. In sexual medicine, in sexology, judgment does not help us in any way to move forward. The patients will only become closed, and they're not going to share the truth with you. So that's very important. Now, open-ended questions and closed-ended questions are equally important, but the art of sexual history taking is knowing when to ask the open question and when to ask a closed-ended question, right? Now, for example, one of the popular questions that I ask is, what does sex mean to you? Okay, sex does not mean the same for everyone at every stage in life. Now, there was a study done by Cindy Meston in 2007 in Archives of Sexual Behavior. Those who are interested, they identified 234 reasons to have sex, right? So it's not always about intercourse. It's not always about procreation, or it's not always about recreation or relation. So it's important to ask, what does sex mean to you at this stage in your life? Now, be very careful. That's why I put that image there, the warning button. When you're intending to ask the question why, you need to be very careful, because the question why comes out very judgmental, okay? For example, a woman went and asked the doctor, and she was in a married relationship, and she wanted to have a STI check. And the doctor said, why? Okay, so that's enough. Oh my God, that's very judgmental. Okay, so the patient will not go and ask the doctor again. And likewise, a woman who had difficulty with orgasm went to a gynecologist, and after taking some history, and she never experienced orgasm, but the relationship was about to break. And then the doctor asked, why is it so important? Why can't you just accept that you can't orgasm? So asking why needs to be very carefully worded, and it needs, and I would not encourage you to ask very early in the session. Now, the second part of his sexual history taking, as I said, it's about understanding the person or persons if they have a partner, and then understanding the problem and the context. This is very, very, very important, right? Because there is a tendency to diagnose anything and everything with a known erectile dysfunction or premature ejaculation. That's not necessarily needed. Now, as you can see in the image, not all sexual problems are dysfunctions. For some, a problem could be merely a concern, okay? A lot of patients in the last 15 years who have come to me thinking that they have something abnormal, not necessarily they have something abnormal, they don't know what is normal. So therefore, it is merely a concern. Doc, whether I'll be able to have sex, whether I'll be able to please my partner, my penis size is only 5 inch, 6 inch. So these are concerns. These are not disorders. These are not dysfunctions per se, right? But preoccupation, whether I have a small penis, whether I'll be able to satisfy, could cause stress, and stress can impact on erectile functioning. So you need to understand that behind every problem, there is a human being. So if we ignore the human being aspect, just go into the problem, that's a very narrow stick view of addressing a sexual problem. And the other thing is, do not try to separate mind and body. And this slide will explain that. Oh, this is all to do with the body. This is all to do with hormones. Oh, this is all to do with your mind. And if I'm not 100% sure, you just call it mixed etiology. That approach is no longer true. Now, the image that you see at B is, it's never separate mind and body, because whatever you think in the mind is experienced in the body, and whatever you experience in the body, you're going to be thinking in the mind. So one other take-home message is, do not separate mind and body and consider it together. Okay, and it's not just about organic or psychogenic. There are relational issues. Now, for example, you cannot expect good sex in a bad relationship. Doesn't matter what you do, what medication you do, if the relationship is very toxic, no way on earth you can expect a good, satisfying relationship. So there are certain elements that we need to understand. Socio-cultural aspects, health literacy, okay? That now in 2023, there's more than enough sources to gain knowledge. But what we are lacking is the ability to apply that knowledge in decision making, and that is what we call as health literacy. So a lot of people who are very literate, they might be holding a PhD, they might be highly educated, but when it comes to health literacy, they don't have a good grasp of it. Even if they don't understand what the body parts, what the function of different body parts, when it comes to sexuality, they rank very poor. So that's something we need to keep in mind. Now, this is a very important slide. I give lectures just on this one slide for an hour because it's a very important and very dense slide. It might not look like that, but it is actually. Now, when we are taking sexual history, what we are trying to do is we are trying to understand why this person is having a problem. Why not others? Why this person is having a problem? That is the first factor, which is called the predisposing factor. Why this person? Then comes the second question, why this person did not have the sexual problem 2 years ago? Why is he having the problem now? So that is the precipitating factor. Now, yes, something would have happened in the first sexual encounter, or he might have felt very stressed and anxious, but that is no longer true. Now things have all settled, but why the problem is still there? So that is the perpetuating factors, or otherwise called maintaining factors. Now, there's also another factor that when a person comes and sees you, or when a couple is having a sexual problem, it's not that everything they have is a problem. They might still have some hopes, and there'll be some factors that we as clinicians could actually work on. So those are called protective factors, and we'll see each one of them in detail. And also remember, there are contextual factors, which I've already mentioned. Now, what are some of the predisposing factors? Okay, so somebody, why this person? Probably there could be an anatomical deformity, like what Dr. Vasan was telling earlier. There could be an anatomical issue. And like what Dr. Atmik Jain was telling, there could be a hormonal irregularity. And say, for example, if the person had a subclinical hypothyroidism, or if it is an autoimmune Hashimoto's disease, and if it wasn't recognized early, the energy levels could be very low. So there could be lots of constitutional factors that we need to take into consideration. And so does the personality traits, okay? The narcissistic personality traits and all those things, they might have a very different way of processing a sexual situation, right? And then we have so many developmental factors, okay? What was the sexual experience? And this is where it's important to know, where did they get their knowledge about sex? And sometimes in my clinical practice, I wish the person did not have any knowledge about sex. That is a blessing, as opposed to someone having all the wrong knowledge about sex, because a huge chunk of my time goes in erasing all the wrong information, making them unlearn everything that they have known about sex, and then making them learn about it. So these are all predisposing factors that we need to be mindful of. Then we have the precipitating factors, okay? COVID, for example, a lot of people during lockdown were forced to be with their sexual partners, and that could be a precipitating factor for some to actually experience a problem. And for some others, it could be a protective factor where they're actually able to sort out and have a bit more time. They don't have to rush, get up and go. So it worked good for some, not so good for others. So we need to look at what has happened in their lifestyle. Okay, have they taken on a new job? What is the stressful events happening? Okay, so these are all very important precipitating factors. Perpetuating factors, as I said, you cannot expect good sex in a bad relationship, full stop. If they're on a medication for a long time. Now, when I say medication, it's not just the prescribed antipsychotics or antidepressants. Medications can come in so many different forms, okay? It could be herbal products, it could be a lotion, it could be hair shampoo. Now, for those of you who need to know, there are certain hair treatments like finasteride, and there are minoxidil is not so bad. We don't have much information, but finasteride, which is used in a lot of hair growth treatment, could have a significant impact on erectile functioning. Now, if you don't know that information, then we cannot address it. And when we ask medication, we need to tell our patients what we mean by medications. It's not just the one they put as a tablet or take as injection. It comes in different forms. Now, contextual factors, we've already talked. For some, their partners are working in a shift, and the opportunity to be sexual is very minimal. And sometimes they don't have enough space. Not everybody is having a big bungalow as we see in Bollywood movies. There is only one room and there's a kid sleeping. Where is privacy to be sexual? So there are so many contextual factors we need to take into consideration. And protective factors, okay? The couple, if they both having an issue, but they agree that they both having an issue and wanting to get the problem sorted is a good sign on itself. So that is a protective factor. And if they are communicating well, then we can use that factor to help the couple solve the problem, right? Now, the third one, now I'm sure you all be waiting or give us the questions, okay? I am coming there. So the case formulation is the third purpose of taking sexual history. Now, what that sexual history looks like, okay? So we need to start with a little bit of lifestyle information. Now, starting with lifestyle details serves a couple of purposes. One, it is not very confronting to your patients. Straight away, if you ask about masturbation, it could be quite confronting to them. So start with some very simple day-to-day questions, easy to answer questions. And then you can slowly slip into medical and surgical history And the important, also ask about any injury to the brain or the head injury or low back injury. Even if it happened many, many years ago, it's important to ask about injury. Then and after the first two, you can see the history slowly moves into somewhat sensitive, okay, the relationship aspects. And then you start asking questions about sexuality, okay? So what was the developmental? What was the first sexual experience like? Where did they learn about sex? What was their masturbatory habit was? So all that you start packing. And let's not forget, and as I said, 2023, we cannot just be very binary, okay? There could be a person with non-binary, and we need to ask what gender would they like to identify themselves with. And then we need to start talking about sexual functioning, right? Now, a word of caution, medications I've already mentioned, and tools I've said, they are great. You can use some tools. You can get some objective scores about it. And you can use, if you're doing a little bit of research project in your practice, but please do not rely on a score, okay? So that's a take-home message for today for sure. Now, these are the questions, and I have it as a pro forma, and I'm more than happy to share. Probably I'll put it in the chat box, or I'll send it to Dr. Neeraj. Now, it's important. These are questions that I don't give these questionnaires to my patients. Number one, I have it in my system. I go through with them when they go through the questions. Now, as you can see, when we're talking about lifestyle, do not forget to ask about sleep, because there is so much evidence to link sleep with sexual functioning, right? Now, snoring is very important, okay? Now, sometimes we need to demonstrate the difference between snoring and sleep apnea, okay? So I'm quickly going to do that snoring. Now, how do you explain sleep apnea? So that's obstructive sleep apnea. We need to be able to demonstrate, because so all other things are very important as well in terms of lifestyle history taking. Now, medical and medication, this is something you will swim through easily, because this is the bread and butter. We always know what conditions, when it was diagnosed. It's important to have it on record. Relationship, once again, we are not relationship therapists, we are not relationship counselors, but it's important to ask some basic information, right? Now, the question 3 is not always an easy question. It's very hard to put a number to a relationship. But if you start talking about satisfaction relationship, patients will talk for 1 hour about all the problems they have in the relationship. We don't have that liberty of having that time. So, okay, tell me on a scale of 1 to 10, how would you rate your satisfaction? Now, when they're rating this has got nothing to do with sex. Okay, we need to be very clear. Generally, how they get along as a couple. Okay, if they give 7, okay, why 7? What made you to give 7? What is good for giving 7? Okay, rather looking at the deficit, why not 8? Why not 9? You can focus on the asset approach. If you're saying, why didn't you give 9? That's more of a deficit approach. So it's good to have some understanding why they are giving that rating. Now, sexuality. Now, this is very important, right? For some of you, you may not focus too much on gender, but I'm practicing in Australia where we need to be mindful of gender. We cannot just assume everybody as male and female. So we need to be mindful of gender and whom they are attracted to. And as I already said, what does sex mean to them? And the first sexual experience is very important, because a lot of us still, that's the first building block we had. And then where did they learn about sex? And it's important because in Australia, I do practice a trauma-informed practice. So we need to understand what sort of negative sexual experience, whether it is a sexual trauma or non-sexual trauma. So we need to be mindful of that, because in India, we cannot be ignoring these topics anymore. Practices need to have some awareness. And I would like to put to the ICOG team, next time we need to start talking about trauma as well, sexual trauma as part of the certificate course, right? Now, masturbation is my topic. So this is my PhD was on masturbation many, many years ago. Now, as you can see, how do you masturbate? And sometimes one of the questions was asked, okay, they can masturbate, but then they cannot ejaculate when they have partnered sex. There are very many reasons, because masturbation, they have the control in themselves, whereas partnered sex is different. With masturbation, they have a different form of visual stimuli. Partner sex, they don't have the same level of visual stimuli. In the purpose and goal in masturbation is different as opposed to partnered sex. And those men who masturbate, if they use a particular way, some men use hand, whereas some men, they don't use their hand, they lie on the bed with the penis being rubbed against the surface, and that's called idiosyncratic style of masturbation. So men who masturbate in a particular position using a particular hand, you ask them to do it in a different way, they struggle, okay? So this is called neuroplasticity. If you start doing something over 1,000 times, you start forming an axonic connection. So it's called neuroplasticity. And some men, they have programmed to masturbate and ejaculate and experience orgasm in a particular way. And when that gets challenged, they find it difficult. It's not that they cannot, they need to be guided, they need to be supported in the transition, right? And this is something important. Remember, there are three parts: the thoughts, the feelings, and behavior. Now, three parts: the thoughts, the brain, and then we have the feelings, and then we have the behavior, which is masturbating. For some men, all three are aligned. If masturbation is totally fine, no religious issue, no health issues, they feel good about masturbating, they continue to masturbate, no issues. The second scenario, they think masturbation is wrong, they don't feel good about masturbating, they don't masturbate. That is fine as well. But the third category is they think masturbation is wrong, but then they feel somewhat nice when they masturbate. While masturbating, they feel good. The moment they finish masturbating, they feel guilty. So you can see there is a misalignment between the thoughts, feelings, and behavior. That's when a lot of problems start coming in, not because of the behavior, but it's their misalignment of the behavior with their thoughts and feelings. So that's very important. Now, partnered sex, I think this will be the most relevant section for a lot of gynecologists. Now, you can, important, if you ask people in the last 6 months, how many times have you had sex? Okay, and I do it on purpose with my patients. How often have you had sex? Or we had once or twice in the last, once or twice in a month. Then I give them a definition. Okay, sex is not just about intercourse. Sex is about touching, kissing, hugging, caressing, massaging each other. And then about intercourse is a part of it, or that we do 4 times in a week. So a lot of lay people still consider sex is about intercourse, but as a sex therapist, I try to challenge that sex is not just about intercourse. Intercourse is part of sex, right? So you need to be mindful of that and asking about what positions they are trying, and they try different positions, whether this couple has got a sexual schema, whether they have a playbook to do with, or they always do the same time, the same way, and nothing is changing, okay? So you need to be understand. And lights on or off, it could sound very simple, but someone who does not have any knowledge of the sexual anatomy, then they wouldn't know which orifice they are actually trying to penetrate in. And that has happened very many times. And sometimes, we need to talk about, it's okay to have lights, and then it's okay to, learn about it. And we need to give them the basic education by giving some hand diagrams. Probably we need to explain to them. Now, male sexual functioning, once again, early morning erections. Now, early morning erection is one question that I want to ask. If early morning erections are happening, well and good. Okay, it is somewhat a good indication that the mechanism is still working fine. But if somebody says they haven't seen an early morning erection, it's not end of the story, because it depends on their sleep hygiene and sleep routine, okay? And early morning erections has got nothing to do with sex. It's a normal physiological process. In a healthy male, they get about 4 to 5 erections. If they are lucky, they wake up with an erection. but that is purely an autonomic nervous system. It's a full bladder, it's a parasympathetic, and then once the bladder gets emptied, you get the sympathetic tone, and then you lose an erection. So it's very important. Early morning erection is a good indication. If it is there, it is reassuring, but if it is not, it's not end of the world, right? So does a list of questions for female sexual functioning. We have a lot of questions that we can go through. Now, this is how a case formulation looks like. No way on earth I'm expecting a gynecologist to do this, but just to let you know that formulating a sexual problem has many components, and not everything that you can deal. You can say the biomedical, I can deal with the predisposing and precipitating, probably perpetuating, but psychosocial and interpersonal, I need to know whom to refer to. Now, that's the last section, and education is very important. Ask about functioning, legitimize the problem, and then if you think you don't have the capacity, refer them out. Education, one simple point, sex is not equal to intercourse, right? If you don't know, you don't ask. Now, through these courses, you know, you can be confident asking, and listening can be very therapeutic. And other thing, do not assume in sexual history taking, and you don't have to be a sex expert in order to help your patients with sexual problems. Closing slide, establish yourself as a resource your patient can trust and approach. Open the conversation. It's okay if you don't know the answers for everything. Don't be afraid to ask clarification and know your referral points. On that point, 4 seconds to be left. Done.
Excellent, Dr. Vijay, excellent. And once again, I must say your dedication and passion for teaching on this very important aspect. I know we all are gynecologists, but you have, I mean, it was an eye-opener for us, because we never ask these questions to our patient. Most of the times we say 40% they suffer in silence. So, I mean, at least you have educated and sensitized we gynecologists about some basics of history taking as far as the sexual health is concerned. So I appreciate your time, your effort, and your passion for logging in from Sydney to educate our FOGSI ICOG members on this very, very important topic. Thank you so much.
Excellent. And I will share the performer, Dr. Neeraj. Okay.
Everyone is asking for that.
All right. You continue. I will put it in the chat box.
Thank you so much.
Thank you, Vijay sir. Sorry for inconvenience for getting up for late.
That's right. If the request comes from you, Dr. Neeraj, it's very hard to say no. Okay.
And Dr. Vijay, can I request you to please, before leaving, can you answer the queries related to the chat box? Yeah. Thank you so much. Thank you.
So let's move on to the next one.
No, sir. Dilpreet, there is one question.
Yeah.
From Ashwini. Yeah.
That's right. I think it really, Ashwini, it's a very good question. We don't want to be sitting and just observing the couple fighting all over. Okay. So part of sexual history taking, once we trigger, there is a trigger warning, then we should know when to stop it. And then you need to direct the conversation. Otherwise, you'll be sitting there and listening all day, every day, fighting. But yes, if the problem is too complex, then I would recommend to see separately. Probably you can see the female, and then if there's a male person, they can look after the male patient. But there is no hard and fast rule. It all depends on how the patient presents to you. All right.
Thank you. Thank you so much. Queenie, let's go to the
Yes, ma'am. Thank you, ma'am. Dilpreet, please.
Yeah. Thank you, sir. It was indeed a great talk. So starting from basic, we started with the basic physiology anatomy. Now moving more towards the dysfunction aspect, we have last talk. For that, we have another renowned international faculty with us, Dr. Muhammad Shamsul Ehsan. He's president at South Asian Society for Sexual Medicine and working as sexual medicine specialist in Bangladesh, Dhaka. I welcome you, sir, for your talk on sexual dysfunction.
Good evening, all from Bangladesh. It's my pleasure to be here, and I feel very much privileged. I can see my friend Dr. Vijay. We had been together in in Hungary, Budapest. Can you recognize? Huh? It's
Yeah,
been long.
yeah, it's been long.
So I hope you're doing good.
Yes, thank you, Dr. Aslam. Thank you.
I feel privileged to meet again the old friends. We had been together in Oxford. It's called ESSM School in Hungary.
Yep. Yep.
So it's been long. Can I share my slides, please?
Yes, sir. Yes, sir.
Is it okay?
No, we are not able to see.
Is there any Vijay? Did you close your slide?
Yeah. I've closed it straight away.
Okay, then. I am not sure with what's going wrong.
Tignes, can you help? Tignes, are you there?
Yeah, he will help. I will call him.
Now, while waiting, if somebody want to have a question, have a word, let's not keep it quiet. It might lose the momentum. If anybody have, we are here to both Dr. Ashan and myself. If you want a question to throw it to us.
Sir, can you see the share screen below the Mohammed, sir? By clicking it is not coming anything?
No, it's not coming anything. My one is MacBook.
Okay. Mohammed, maybe you can send your presentation to Dr. Neeraj.
Meantime, you can answer, Dr. Vijay, if you are here with us.
Yeah. I'm still there. Okay, I think we need definitely. I think okay. That's exceptional teaching. Okay. Can frequency of non-coital behavior like kissing, touching?
Can you post your question again?
No, I'm looking at it. It's Neelam Sodhi. The response could perhaps be occasional frequent. This is an interesting, encouraging query for the patient too. Sort of teaching. Excellent. Look, I think when we talk
Dr.
about.
Vivek, can you post your question again?
Sir, are you sending it to me or?
I'm sending it to you, sir.
Okay.
Can you see it now?
Dr. Vijay, are you with us?
Yeah. I'm reading.
So can you please answer this question? Can frequency of non-coital behavior can be quantified? Yeah.
Okay. I think it's very hard to quantify anything.
We can't hear
in
you,
sex.
Dr. Vijay, please.
Oh. No, I'm talking. I haven't muted. See, I think quantifying that is.
No.
You can't hear us?
Yes, we can hear, sir.
It's audible. Yeah, it's audible.
Yeah, it's audible. Probably.
Audible.
No, I think the non-coital things, whether it can be quantified, I don't know what is the context of that question. Why do we need quantification? But it's important to talk about that. Say, for example, if a person is able to enjoy all of that and give and pleasure to the partner, but not just able to perform intercourse, is it even appropriate to call they have a sexual dysfunction, right? They are having dysfunction with intercourse, but they are able to perform. And that is very reassuring to patients to tell that they are able to do all of this. And this is also part of sex. Now, for that very reason, I do not use the term foreplay, because when we say foreplay, somehow the mind thinks the play is intercourse, right? So it's everything. The moment they start kissing, that is part of the play. So that's how I would explain that. And is religion important? Importance of religion in history, yes, but it shouldn't come across very confronting, where there are elements of, like belief-based. If some of the beliefs are making the is precipitating or perpetuating the issues, then we definitely need to bring that in, but very carefully, because religion is a very sensitive topic. And how can you advise newlywed couple to switch from masturbation to normal vaginal? Okay, so this is once again, when you say normal vaginal intercourse, who says that is normal? Okay, so you need to be very careful in sexual history taking when using the word normal. So probably switch from masturbation to vaginal intercourse. They don't have to switch. Okay, they can still include both. They can combine it together, and then they can use it to stimulate to a certain point. And then we can rope that intercourse and masturbation together, because to give up totally and switch could be difficult. But once again, depending on every couple, what to advise to take precautions for exam patients, especially of opposite gender? Well, I think that comes to the code of practice and your comfort level. Okay, so I generally don't examine female patients.
Yes, sir. Can you see my slides?
No.
No, have you sent to me?
Oh, yes, I have sent to you.
I have not received.
Sorry, sir.
Vijay sir, there is a very practical question, because we gynecologists, when we are practicing the sexual medicine, so we gynecologists have to do obstetrics, like do operations and everything. We have to see. So for those gynecologists practicing, what your advice, how to take a sexual history? Because I have seen, and even I am practicing sexual medicine, and many times it will take half an hour, 40 minutes to get, first the couple, from both the couples, and individually the female, the male. So it is many times it's very difficult. So many gynecologists are avoiding those questions, asking the sexual history. How to do that? Yeah, what's your advice?
That's right. So as I think I've said it in the past, lot of doctors, especially those who are not practicing sexual medicine, when that's not their primary profession, it's not that they don't want to ask questions. It's not that they are less human. They know the importance of sex. But the problem is, I don't know what to do with the answers I get back. You can ask the question, but what do I do with the answers? Therefore, let's not talk in the first place and move on. But you need to understand, Apuba, if you're having a flourishing practice, find a counselor in your area that can help you. Know your referral points. That's what I said. If you can have a nurse, or if you can have somebody within your hospital who can spend the time to take history, and when you see the patient, you have a summary of that information in front of you. And that is one way to address practitioners who are focusing on other things and then want to do sexual medicine. Because if I have to say, you can't take sexual history in 10 minutes. Okay, you can get to know the symptoms, but sometimes we rush into diagnosis, and that diagnosis, and then we start prescribing. When the prescription doesn't work, the patients start thinking, oh my God, I went to the best doctor in the city. They gave the best medications. The medications is not working. I am a failure. They don't blame you. They don't blame the medication. They blame themselves, right? And I've seen situations like that a lot in the past, where patients been given a label and the partner was, I'll give you a very short story, scenario. A couple come, they're sort of newly married couple. The guy had about high school education and the girl had a master's degree. The guy came in, he said, doctor, I have erectile dysfunction. I told the male patient, look, that is for me to tell at the end of the consultation, tell me what your problem is. He said, and then he showed me a small booklet with written erectile dysfunction in red ink with 10 different medications. Cut the long story short, the women, she came in later, the history went, and she was having, she was contracting the pelvic floor muscles. She was, getting very tense. What would be your diagnosis immediately? What you'd be thinking of? Vaginismus. Oh my God, this is a case of vaginismus. But in fact, it wasn't. When the penis was coming closer to the vaginal introitus, she has an excessive feel to urinate, and she felt very ashamed of that. Therefore, she was voluntarily contracting the muscles, which is not by vaginismus. Okay, so anyway, I have Dr. Ashan here already. I've already taken some of your time, Dr. Ashan. Go for it. So I can talk about sex for hours and hours.
You can interact in the chat box, Dr. Vijay.
Yeah.
I'm so sorry for the unintentional delay, and sorry for my being a very technologically retired. So I'm just using my new laptop, so I'm not very acquainted, but it's not working the way it was. So anyway, no further, details. I'm Dr. Mohammed Shamsul Hassan from Bangladesh. Can anyone please upload the slides on behalf of me, please?
Yes, Neeraj was sharing, na? Neeraj will do when it.
Okay, so it's a quiz for all of the esteemed gynecologists. So which is the most prevalent female sexual dysfunction according to DSM-4? Option one is the female hypoactive sexual desire disorder. Option 2 is the female orgasmic disorder. Option 3 is the female sexual arousal disorder. And option 4 is vaginismus. Option 5 is dyspareunia according to DSM-4. Anyone has any idea which is the most prevalent female sexual dysfunction?
Sir, can you see the slide?
I can see it. Yes, thank you.
Okay.
Please change the slides, please.
Yes, I have said, can you see the slides?
Yes, I can see it.
Okay, okay, sir.
Can you please change the slides, please? I can see one person is telling female dyspareunia, one was telling arousal disorder. Fine. And also sexual desire disorder. And she is right. Female sexual desire disorder is the most prevalent female sexual disorder. Female hypoactive sexual desire disorder, HSDD we call it. And in case of male, it's the premature ejaculation. So male and female varies in so many different ways. My earlier faculties has told us. So while talking about the counseling, we have to understand that male and female have subtle difference. While we talk about the female sexual dysfunction, okay. So can you see the slides, please? Can anyone change the slides for me, please? Okay, thank you. Change the slide, please. Okay, so it's my previous slide. So there are a lot of, I just sent the earlier slides. So counseling in sexual medicine, what do we call it counseling and what we call it sex therapy? Counseling is more of a general term where we are giving advice and guidance to the physical, biological, psychological, and social aspects of sexuality, while also increase the opportunity to find the fulfillment and make a meaningful sexuality that will enrich the person positively and also enhance the personality as well, and increase the communication and love. And role of the counselor is essentially to prepare the patient's choice to change. Next slide, please. And counselor has to have certain skills like personal ability. You have to be to some extent charismatic because you need to convince your client while giving psychotherapy, and your personal ability skills also matter to some extent. And you have to be genuine. Whatever you are telling to your client has to be accepted by the client, because if he feels you are genuine, he's ready to accept. Also, there are certain situations where you need the immediacy. While certain situations it needs a very immediate. So counselor has to have the immediacy, and he has to have the empathy. He has to put his feet into his client's shoes or her shoes, and he has to have a positive regard and respect to the client. Next slide, please. Whereas psychotherapy applies to the appropriate evaluation and psychotherapeutic treatment for the sexual disorders, and the person has to have the certain skills, and he has to have some appropriate knowledge to deal with the clients and their sexual dysfunction. And whereas we treat patients with medicine which quantitatively increases our our well-being and other issues, whereas psychotherapy helps us to have a qualitative life. For example, if we give premature ejaculation patients a dapagliflozin or SSRI, it gives them increased timing. In case of premature ejaculation, if you give them dapagliflozin, it will enhance their timing, whereas sex therapy gives a satisfaction. Not always these two are similar. Next slide, please. Psychotherapy should be open, patient-centered, and it has to have combined with the patient's etiology and management. Like always you cannot treat a patient with medication only. Sometimes you need to have the counseling, and while we give both psychotherapy and counseling together, it helps the patient in the most efficient way. Next slide, please. And we should not be very rigid. We should not be very, we should not, psychotherapy is not a cookbook. Not always you will look upon the book and say, these are the things, one happens after another. Each of our client is individual. So whenever we are giving psychotherapy, we have to see it in a perspective that every client is individual, not all, one solution fits to all problems. Next slide, please. And we have to understand, like Dr. Vijay said, that in 2023, our clients not always be a male or female. They may have transgender issues. They may have other issues. They may be, sexually neutral. They may be asexual. So some of our clients may be widower. They may be in open relationship. And our personal belief system, our religious view should not be imposed upon our clients as well. So whatever we tell our clients, it has to be from the client's perspective is the best solution for them. Next slide, please. One of the important key issue in psychotherapy is to gain the client's confidence. We need to give them an informed consent. We need to tell whatever we are prescribing to our clients. Maintaining a professional and unbiased specialist. At one point, I referred my client to one of the therapists, and the client said, look, that lady and I belong to the same, socioeconomic culture. We share the same bar, we hang out with the same crowd, and she's a verbal diarrhea. Whatever I will tell to her, she will speak out to my whole community. So I'm not very comfortable with the, sharing my own thoughts with the client. So whenever it comes to sexuality, it's very, very unique, and you have to be very, aware of the confidentiality and other issues. We have to have a, efficient way. We need to maintain our professional standards and not disclosing our information to our other clients. And we have to have a cultural appropriateness. Whatever is happening in the way the psychotherapists and psychiatrists are giving psychotherapy in Western world cannot be practiced in India. So we have to understand the cultural and ethnic issues. Next slide, please. So not all of our clients, like Dr. Vijay has said, needs to be treated from the psychotherapy, which is, not all of them has to be CBT expert. Not all of them have to be sensate focus expert. So according to International Consultation of Sexual Medicine, they have prescribed that there will be 5 steps of delivering sexual medicine treatment. And many of the states were discussed by Dr. Vijay earlier and other, Dr. Atomic Jain. So I will go and slide through the, I will go through the slides very shortly. So 5 steps of algorithm proposed by ICSM, that is the International Consultation for Sexual Medicine, chapter 4. They have said that there has to have a biopsychosocial approach. It has to be multidisciplinary. Not always a gynecologist or a urologist or a psychotherapist alone can solve the problem. Sometimes we need to see the clients from the multidisciplinary, multi-person's approach. So one client can be given treatment by many of the therapists or doctors. Next slide, please. So traditionally, Dr. Vijay just have shown that the traditional view was we consider our patients as psychogenic, mixed etiology, and organic. But now, can you see our slides, please? Can you see the slides?
Yes, we can see.
Okay, thank you. Now I can see that many of the people are telling that the PDF is opening or not. I'm not sure whether they're referring my slides or not. So anyways, so earlier we used to tell that the etiological aspects of all the sexuality belongs to either psychogenic or organic or mixed. But now it is seen from a multidisciplinary and multi-angle. Next slide, please. As we can see that the current view of sexual dysfunction are of biological aspects, maybe cultural aspects, maybe relationship aspects, maybe psychological aspects, and some are sexual. So one problem has to be seen from a 360-degree angle. For example, someone has got diabetes for a long time, let's say 7 years of diabetes, and the lady is 49 years of age. Now she developed hyperactive sexual desire. She doesn't have the proper desire. And if you see that, and as we know that the female hyperactive sexual desire disorder, diabetes is a big time reason for developing female hyperactive sexual desire disorder. But then again, we have to understand that this lady also may have anxiety trait, which can lead to have a low desire. This lady may also have sexual. They may have incontinence, which can also lead to sexual desire problem. So if you only see that diabetes is the sole reason of developing female sexual dysfunction, so it's not always right, because ashamed she feels about her sexuality can also develop to female sexual desire disorder. Next slide, please. So according to International Consultation for Sexual Medicine, there are 5 steps of dealing with the sexual problems. One is the step 1, then step 2, and then step 3, and then step 4. So in step 1, we need to take the proper history of the clients. Maybe they have all the sexual history considers of sexual history, physical history, and psychological history. And if needed, we need to go for the physical exam, and if needed, we need to go for the lab test. That is the step 1 of dealing any of the patients having sexual dysfunction, both in male and female. And the next step, we need to see if there needs any further intervention. We will investigation. We will go for it. If it doesn't need any further investigation, we will go to the next part. For further investigations, we, for example, someone has got female sexual dysfunction, and also she has got diabetes, and someone has got menopause. We need to see their testosterone level as well. So because that testosterone level, surgical menopause, all can lead to the problem. Maybe she's getting medication for her depression, that also can create a problem. So these are the issues we have to keep in mind. Once we have taken proper history of his sexuality, her medical history, and psychosocial history, and after we do the appropriate test, we will see whether the patient really needs treatment. Because some people will improve only with education. Some people will need medications or psychotherapy or both, but they are reluctant to take the treatment. So we need to discuss with the patient, and we have to give a shared decision making. Whenever we are covering step 1, 2, and 3, then we'll give the certain treatment. It may be part of it may be counseling, part of it may be sex therapy, part of it may be psychotherapy, maybe medication, or maybe surgical treatment in case of male and female. And step 5, we have to follow. Next slide, please. Next slide, please. Next slide, please. So Dr. Vijay has given us an idea how we assess our patients. Though he said that as a gynecologist, we don't have enough time to go for the predisposing, precipitating, and maintaining factors and biopsychosocial. But if you want to see a disease or a disorder from the 360-degree angle, these are the areas we need to fulfill. Next slide, please. Next slide, please. So step 4, we need to see that not all of our patients need treatment. Some people are easier to change. Some people are not easier to change. Some people need realistic goals. Some people have difficult and impossible goals and expectations. Next slide, please. See, at the starting point of our treatment, it's easier for a patient to change. And if they set the realistic goal, so we can give them a better outcome. Patients who are having easier to change and realistic goals are the patients who are willing to collaborate, can see the potential benefits and the success of getting treatment, and achievements and support and motivation. Next slide, please. So if you are easier to change, but unrealistic expectation, that will create a problem. Like change are potentially easy to make, but the patient cannot see the success. Some people have got over expectations. You are giving, for example, someone has got a premature ejaculation. You have given him a treatment with the SSRI, and instead of 10 seconds, he's getting 1 minute, but he's telling, I want more. And if you give further medication, if he gets 4 minutes of treatment, he say, I want more. But whenever, if someone can, last for more than 1 minute, we call our achievement is okay. So our target is fulfilled. So if you are having an unrealistic expectations and goal, despite you are improving, you are not accepting, and that creates a problem. Next slide, please. Some patients are aware of the space for the improvement, but knows the process for change will be difficult. Some people may have, surgical menopause, and they're very, they don't have, sexual desire because they have got a lack of estrogen and progesterone and testosterone. So still they are planning to have the sexual desire like before at the age of their 20s and 30s. So it will be difficult to obtain. So the goals are realistic, but it may be difficult to achieve. Next slide, please. So some are the goals which are often difficult to achieve, and there will be failure of treatment because high level of expectations and high level of standards which you have set for yourself, and which is impossible with the given scenario. So not all of our patients need a proper treatment. Not all of our patients may get proper treatment. Some of the patients will never achieve their desired goal. So based on the expectations of their goals, either realistic or unrealistic, and some people have got it easier to change and some are difficult. Next slide, please. And whenever, step 4 is whenever we are giving treatment, we have to have a proper idea whom we should give psychotherapy, whom we should give medication, whom we should give both. So not all of our patients will get the same sort of treatment and same sort of achievements. So like I said in earlier slides, there are 5 goals and standards. The step 1 is we need to take the history, and then from the history we should take the appropriate history from physical, psychiatric and medical history. If needed, we take the lab investigations. Once we are assessing the patients properly, we need to do further specific investigations, which we don't do. We don't do it for all the patients, but for some special patients may need this treatments, and not all of our patients will need treatments which are based on CBT. Like CBT is not all the psychiatrists or psychologists are a CBT expert. CBT means you are changing the patient's cognition and behavior. So and not all of your patients will need CBT. Not all of your patients need sensor focus. Some of the patients will only improve if you give them a proper talk, if you give them the proper history about their, if you tell them about their, human sexual response cycle and proper psychoeducation. So, and you need to give them follow-up as well. Next slide, please. Next slide. So what are the type of psychosexual therapies? So there are behavioral therapy, there are cognitive therapy, systemic therapy, and psychodynamic therapy. This is a very old slide. My newer slides I will send you again, so you can correlate with the things. So in summary, what we do, if we know that the person develops these symptoms, which is a learned behavior, like according to behavioral therapies, they understand that sexual problem is a behavioral problem. They assume this hypothesis when they see their diabetes, depression, and all the other physical and psychiatric illness are not there. So they have got the problem because they have got so much of anxiety and depression or whatever. So if sex therapy is considered as a learned behavior, we have to unlearn the behavior. So the behavior therapists say that sex therapy is a learned behavior. So we need to give them desensitization and other ways so it can be improved. Some have got cognitive problems. Some people think that they are a failure. To be a man, you have to successfully, last for 20 minutes. If you have to be a real woman, you have to satisfy your husband all the time. And if someone has got unrealistic expectations, they need their CBT, they need cognitive behavior therapy. Systemic therapy or marital therapy thinks that the sexual problem is a couple problem. It's not a problem of the patient or the partner. It's a couple problem. It's a combined problem. We need to realign the couple's dynamics, the way they interact with each other, and eventually we can solve their problems. So that is the systemic approach. And psychodynamic approach is the Freudian concept, where it says that sexual problem is a behavior which was which has happened in the past. If someone has got childhood sexual or physical abuse, they develop the anxiety and fear, and eventually when they try to have sex in their adult life with their partner, they have a severe anxiety and startle response. So psychodynamic therapy says that it's a childhood physical or sexual abuse causes problem, and you need to you need to change their way of thinking. Next slide, please. So behavior intervention is censored focus. The Master and Johnson's typical model was based on the censored focus. As I said earlier, it's a learned behavior. They have got 3 different stages. If someone failed to consummate, they fail to have sex with her partner, then they have got a behavior therapy. Initially, they relax the patient. They give them touch. The client is advised to touch his partner when the partner will lie down on the couch doing nothing. And once they are allowed not to have sex, intercourse is prohibited. So the person's expectation to enter the penis in the vagina gets lessened. So eventually he started enjoying the other ways of touching. So because once someone is very much afraid of penetrating and he is unable to penetrate into her partner's vagina, so they develop so embarrassed to themselves, and they develop so very anxious. So eventually they cannot they cannot penetrate into their partner's vagina. So eventually they develop the behavior problem. So they are allowed to touch only without having sex. Then his partner is also suggested to touch the partner. It's a reciprocal touch. They touch each other. Then they are allowed to touch the private parts of the vagina and clitoris without penetration, and the breast as well. And eventually they intercourse the vagina, and once they start pushing into the vagina, they don't do it push and pull, no pelvic thrusting, and eventually they do it gradually. So it's a censored focus where you do the things gradually. Systematic desensitization is a way where the person is severely catastrophized. He is very much anxious of getting into the intercourse and the foreplay. Some women, if they have got the earlier childhood abuse and they have got an anxiety trait, they feel very much ashamed and afraid of touching each other. Next slide, please. Next slide. Okay, keep it there. And so gradually they are given relaxation. They are making assurance and giving advice and support, and eventually they help to get penetrated. They are giving some advices in the therapy, and they are allowed to do something in their home. So they practice and come to the next session, and eventually, gradually, they overcome each other. Stop and start technique is a special form of behavioral intervention which was proposed by Seaman. Seaman is a scientist who said that let's say it's a penis where it's a glans penis, and it's the the shaft of the body. If during the intercourse, if the wife, if you consider it as a glans, the wife will touch with her thumb to the dorsal aspect of the penis, and one thumb will be on the glans and one thumb will be in the shaft of the penis. They will just press it for 4 seconds and then release the pressure. 4 seconds and release the pressure. So that is called a squeeze technique. And stop and start technique is for the unmarried guy who are given counseling so that he will try to masturbate himself. In a scale of 0 to 100, when 100 means he will ejaculate and 0 means no erection, after 70 to 80% of striking the penis, and if he feels further stroke will lead to discharge of semen, he he will stop himself. So that is called the stop and start techniques, and gradually increases his ceiling and increases timing. So guided and directed masturbations are special techniques which are given that the person is allowed to do sex. The person is allowed to masturbate in front of his wife and gradually penetrate inside the penis. And mindfulness is is just more aware of the surroundings, and it's a special form of technique where the people develops more of their awareness around the surroundings and to the body parts. So eventually they get less sensitized. Next slide, please. According to cognitive behavior intervention, it is three things: identifying the thoughts, which are the thoughts that leads to developing problems, and how to evaluate these problems and modify. So according to CBT, these are cognitive behavior therapy. These are the the certain cognitive distortions we have, like we are incapable, will not be able to have proper sex, will not be able to satisfy our partner. Then it causes us problem. And once we can change our thoughts by analyzing the behavior, pros and cons, and other techniques, and giving scientific education and suggestion, we can modify our thoughts. So that is the whole of CBT. Next slide, please. Next slide, please. Next slide. Systemic therapy, where like I said earlier, that every sexual problem is considered as a couple problem. Whenever the male partner has got premature ejaculation or erectile dysfunction, or the women have got the vaginismus, they consider it's a problem of the way one interact with the other. For example, a wife has a vaginismus, he is not helping his partner to penetrate. He's so afraid of getting penetrated. Then according to systemic therapy, it's about the partner's reaction that enhance the problem again. So it's a reciprocal things. One, the wife is getting vaginismus, the person is not allowing her husband to have sex, and the reaction of the husband also demoralize the wife. So it's a personal growth and independence that needs to be improved. Please tell me if I am going beyond my time, because I am at the very beginning, running short of time. Next slide, please.
No, it's okay, sir. It's okay, sir. No problem. You can finish.
Like I said earlier, the psychodynamic theory, they have said that there is a certain dysfunctional process in the development. According to Freud, they say that there are 3 stages of development. According to the Freud, oral development at the age of 0 to 18 months, there is an oral development where the person sucks whatever comes to their mind, a child. And 18 months to 3 years is the anal stage, and then the phallic stage. According to Freud, the problem lies in the phallic stage. If someone get abused in the childhood or in the other stages, they have got a frightening response to the intimacy. And when someone is getting abused in the childhood and at the later life, at the age of 17 or 18, they are trying to have physical intimacy or coming close to each other, then they develop very afraid of each other, and maybe the lady is very much affectionate with the guy, but when it comes down to sexuality, she closes her legs together, opposes to each other in a manner, so fashion, so the guy is almost impossible. It's impossible for the guy to penetrate. So we sometimes call it vaginismus, because at the height of penetration, even not before entering, the person will oppose his lips of the vagina. So according to psychodynamic perspective, childhood physical or sexual abuse can lead to further problems. And the psychodynamic therapists go beyond their child developmental of the child, and they try to dig out what has happened in the childhood, and they give an alternate explanation, and later they give a improvement by solving the problem. Next slide, please. Next slide. Sorry, so there are certain slides I am missing here, because I will show you the slides. There is a Precede model. According to Precede model, not all of your patients need intensive psychotherapy. PLISSIT. PI means permission. Sorry, P stands for permission. Whenever you are planning to have say counseling and sex therapy, you have to give permission to your client, because it's a very sensitive question. You need to ask permission from them whether you are okay to ask about your sexuality or not. Then you give them limited information. Not all of your patients need intensive sex therapy. Some of your patients may be, have myths and misconceptions. For example, very anxious patients may have sexual problem and they feel, I am incapable, I am not worthy of living. So sometimes a good information and scientifically explained information is enough for them to, give the patients a proper improvement. Some patients need specific suggestion. That is the third word. Please see, P for permission, LI for limited information, SS means specific suggestion. For example, a lady, she feels that her vagina is so small to accommodate a big size penis. And he feels that he will be afraid, he will be fainted, he will have a grave consequence once his husband is about to penetrate. So if you give them the sexual anatomy and physiology and how it stretches, it has relaxed during childbirth, and during it has got an immense elasticity, it will help them to get a proper, appropriate information can help her to move together to his partner. Sometimes some people feel so ashamed because sometimes they don't get orgasmic. So Basson's model, which says that not all women get into sexuality just to have orgasm. Many of the women get pleasure by pleasing their partner only. So if you give them a proper explanation of what is the scientific, knowledge and everything, that will help them to, move forward. Some patients need intensive therapy. Then you need to send them to the appropriate persons who are very expert on these fields, like CBT expert, someone who can give cognitive behavior therapy. Some people will develop, some people are expert in sex therapy. You can give sex therapy. I know Dr. Poddini Prasad, she is a gynecologist. My friend is Dr. Satyanarayana Reddy Allah. They are very good gynecologists and they are very good sexologists, famous in India. So many of the women, many of the gynecologists who are expert in sex therapy as well, you can refer them to them only. So Plicid model says not all of your patients need intensive therapy. Some may be given improvement with stage 1, 2, and 3. That is permission, limited information, and specific suggestion. So a good nurse with a psychotherapeutic background, psychological background, can give them only a gynecologist who has the expert knowledge, who have attended these programs, can give them a specific suggestion. So the Plicid model is helpful for many of the busy practitioners in the day-to-day practice. So in summary, counseling and sex therapy is something. Counseling can be given by any persons who have got a proper knowledge, but sex therapy has to be given by someone who has got adequate knowledge. Sex therapy is not a cookbook that if you read out the books and slides, you can give sex therapy. You have to have a supervised training under your supervisor. Not all patients need sex therapy. Some people may be improved with only some specific suggestions only. And I am very much sorry because I could not give you the slides. I will send my slides so that later you can, you can correlate with my topics. Thank you so much. And thanks, Dr. Neeraj and other dignitaries for giving me the chance to talk to in front of a very esteemed audience. Thank you so much.
Thank you so much, Dr. Mohammed. We really appreciate, and we know it was a very, very vast topic, and for you it was really difficult to cover it in 25 to 30 minutes, but you tried your level best to give full justice to the topic allotted to you, and we really appreciate that you joined us from Dhaka and you have shared your knowledge, experience and wisdom with our all FOGSI ICOG members. So on behalf of ICOG, I express my sincere gratitude and thanks to you for joining us for this ICOG training program. Thank you.
Thanks for having me again. Thank you again.
Yeah.
Thank you, Mohammed sir. Thank you, Mohammed sir, for wonderful presentation. We loved it.
Thank you. We learned a lot. For we gynecologists, it's all, everything is an eye opener.
Yes, it was such an elaborate
Yes,
talk, stepwise
definitely.
management, stepwise
Yeah.
counseling.
Is,
Thank
is
you
there any
so much.
question, Queen? Queen, any question there?
Can't see any questions in the chat box. Mitali, everybody is appreciating you, Dr. Mohammed.
Yeah.
Everyone
Thank
is
you so much.
appreciating you. Thank you. So,
Sir, from Epar Bangla, I'm saying Onek Dhonnobad. Ami Epar Banglar.
Thank you, madam.
Onek Dhonnobad.
It's pleasure.
So Mitali, now we will start with our post test. Please share the link in the chat box, and dear delegates, you will have to just click.
1 minute, please everyone attend this post test and finish in 10 minutes, because after 10 minutes you can't assess that question. So please finish within time. And it will be not available later on. So yes, Mitali, share the question.
Yeah, please share the post test link. We will be giving you 10 minutes to solve the post test questions. And meantime, you are solving, we all will be muted so that there is no disturbance for you all. Please share the link and start the timer. Yeah, so link has been posted, and start the timer as well, Mitali. Link has been posted. Please see your chat box. Click on the link and start solving your post test. Mitali, the link is not opening.
मैम यहाँ से तो शुरू हो रही है.
नहीं, it is not opening. I also checked. This link is not opening. Dynamic link not found.
मैम 1 मिनट में चेक करती हूँ.
Neeraj, meantime, you can just wind up today's whole program. The technical team is working on the post test link. It will save our time. Yeah. Yeah, just wait. Technical team will post link again. Yeah. Neeraj?
Yeah, sure. So I hope everybody enjoyed today's sessions. We had a great session with a great speaker. So first we discussed about the overview by Dr. Lakshmi Madam. It was a wonderful presentation. And I said few lines about how gynecologists and sexual dysfunction are related and what we can do for better sexual health for everyone. And our third talk was about the importance of sexual health by Dr. Sanjay Deshpande. He very well said how important sexual function or sexual health is for overall health. And our fourth talk was about wonderful by Dr. Vasan sir about the anatomy of sexual organ, anatomy and physiology. Both he covered very well. It was an eye-opening session for all of us as a gynecologist. And Dr. Narendra Malhotra sir told us about the overview as well as classification of various sexual dysfunction. What are the various male sexual dysfunction? What are the different categories? What are the different classification, as well as female sexual dysfunction? Very well explained by sir. Then Dr. Atmik very well explained about the sexual response cycle. What are the different sexual response cycle and how important it is to know about the sexual response cycle to understand the various sexual dysfunction, because without understanding the response cycle, we can't manage the sexual dysfunction. Then, yes.
अभी मैं पोस्ट कर रही हूँ लिंक.
Okay.
हाँ. ओपन बराबर चल रहा है. 1 मिनट.
I am muted. Mitali, post karo. I will click on the link. I will check whether it is working
Ma'am,
or not.
please check.
Then you start the timer.
Please check.
Just wait. She will post the link again.
Hello, ma'am.
हाँ.
Can you check?
कहाँ आया? नहीं आया ना. लिंक कहाँ पोस्ट किया तुमने?
मैम किया है ना. 1 मिनट मैम.
नहीं किया.
हेलो.
हाँ, नीरज चेक कर दो.
अरे मैंने किया है यहाँ पे टू शिवानी जायसवाल एवरीवन इन द.
एवरीवन करना.
हाँ.
अभी आया, अभी आया.
Now it is come.
हाँ. So dear delegates, now the link, this link is opening.
Yes,
So
yes, it
please,
is
yeah,
opening.
click on the link and start answering your post test. And now we will be starting the timer. Mitali, अभी timer लगा दे.
Okay.
Yeah, the link is perfectly working. Yeah.
5 minutes left.